check, check, check.
ಹಾಂ ಹಾಂ ನೀವು ಹೇಳಿ ನೀವು ಫೋನ್ದಾಗ ಸಿಗ್ತೇನೆ.
A very good morning to all. This is Dr. Vimarsha, Junior Resident, Department of Pediatrics. From the moment of conception, hormones orchestrate the development of organs, the growth of tissue, and the timing of complex milestones like puberty. Pediatric endocrinology is a vital subspecialty which sits at the heart of the beautiful developmental journey of the child. It reminds us that early intervention is not only just beneficial but transformative. By understanding the hormonal disorders present and progress in children, we are better equipped to prevent complication, guide families, and ensure that every child has the best possible start in life. Timely diagnosis and management of endocrine disorders can mean the difference between a child reaching the fullest potential and living a life with preventable complications. With this, SDM, Department of Pediatrics and Neonatology, IAP, Dharwad District Branch, welcome you all to the Paediatric Endocrinology CME. Now, I request Dr. Abhishek Kulkarni sir, consultant in Pediatric Endocrinology and Diabetology. He's a senior consultant at Sir H.N. Reliance Foundation and SRCC Children's Hospital to deliver a talk.
Good morning, friends and colleagues. Always a pleasure to come to Dharwad on invitation of Professor Vijay Kulkarni. So I'm going to talk about the current concepts of screening, diagnosis and management of congenital hypothyroidism. I also like to always coin this talk as congenital hypothyroidism revisited, because some of the screening cutoffs, the guidelines for recall of babies who have higher screening markers of TSH and the treatment guidelines have changed in the last few years. The aim of the presentation is to enable that every baby born in this country gets universal screening for congenital hypothyroidism. There is timely detection and appropriate treatment provided to these neonates. And for that, we need to provide all the clinicians with a uniform, simplified algorithm. So we must have simple take-home algorithms where pediatricians are able to recall babies who have higher screening cutoffs and treat the ones who actually have the disease. Now, before I proceed, we need to understand that we are going to be focusing primarily on primary congenital hypothyroidism, which is the disease of the thyroid gland, and not the secondary or tertiary hypothyroidism, which is a disease of the hypothalamo-pituitary axis. Because the incidence of primary congenital hypothyroidism in India varies between 1 in 1100 to 1 in 1300 live births, while that of central, which is secondary or tertiary hypothyroidism, is 1 in 50,000 live births. So we are nowhere there yet to catch those on a mass basis, though in practice we very well pick them up. But for the masses, we need to ensure that at least this entity of 1 in 1100 live births is not missed at all. So the outline of the presentation is going to emphasize the benefits of universal screening, the timing of screening and the analytical methodology that needs to be used, protocol for recalling infants based on results of the screening tests, and decisions to initiate treatment based on the results of venous thyroid function tests. So one important message from this slide is we do not treat babies based on screening test values. Screen is only meant to identify and not confirm the condition. So you need to recall these babies in a time-sensitive fashion based on the value obtained in the screening test and subsequently evaluate and manage them. Evaluation for etiologic stratification is important, but must not delay on onset of treatment. And I would also be speaking briefly on the treatment and monitoring guidelines that we need to follow. So this is what used to happen in the pre-screening era. Large parts of the country still are living in this era, but we are fortunate in metro cities, we don't see this anymore. So in the pre-screening era, testing of neonates was limited to those babies who had relatives with congenital hypothyroidism, certain ethnicities, or if doctors felt there was consanguinity, or if the mother had an autoimmune thyroid disease, or there was an unusual diet rich in seafoods, or mothers came from iodine depleted regions, doctors would test the thyroid function in the neonatal period. Or if there was a history of long gestation or post-datedness and babies with large birth weights, or if the physical examination at the delivery table depicted large fontanelles, macroglossia, hypotonia, goiter, poor feeding, dry mottled skin, umbilical hernia, jaundice, constipation. So this is what we were taught as undergraduates, that this is what congenital hypothyroidism is. But the reality is 85% of the babies who have congenital hypothyroidism will not manifest anything of this. They are apparently normal looking babies at birth, and it's only the very severe ones where the maternal T4 is unable to mask development of these signs who will present at birth, and that's only a mere 15%. So 85% of the babies will look pink and nice at birth, and hence the need for universal screening. So look what the West has published. In the pre-screening era, they thought the prevalence of the disease was 1 in 6,500. Now with many of the Western countries having universal screening programs, they have blatantly published that the prevalence of the disease is 1 in 2,500 live births. Approximate mean IQ of babies with this disease in the pre-screening era was 86, whereas that in the screening era is 105. In India, you need a much larger IQ to crack entrance exams. Infants with IQ less than 70 were almost up to 25% in the pre-screening era, and look what screening has done. There are no babies born in the West with IQs less than 70 or what was crudely called as mental retardation. So there's no mental retardation related to congenital hypothyroidism in the current screening era. So this, I don't think I need to emphasize anymore why screening universally is important. So this is the Indian scenario. Now, colleagues often ask me, but that's all Western, what about India? So there are ample studies done in India, but the problem in India is we are an amalgamation of small kingdoms. We are not a country. So everyone likes to do their own research. And you see, I have marked the studies where the cutoff used by the researcher is closer to the cutoff of TSH that is used to recall babies. And if you see these 5, 3 of which have been done in the southern part of the country and 1 at my alma mater SGPGI, you will see that the prevalence of the disease is anywhere between 1 in 1,050 live births to 1 in 1,300 live births. And the cutoff of TSH that the researchers or the investigators have used is around 20 and 25. And currently we use a cutoff of 20 MIU per ml to recall the babies. One important thing for doctors working in private sectors, corporate hospitals, is on your screening cards, your newborn screening cards, you must read carefully whether the TSH units are expressed in whole blood or are they expressed in serum. Now, universally across India, everything is measured in serum units. When you prick a baby by a phlebotomy and send the sample, the TSH is always measured in serum units. But if you buy certain international company cards, they might estimate and express the TSH in whole blood units. It's called WBU. It's written in small ink at the side, and you need to multiply the number by 2 to get to the serum units. The Indian guideline expresses the cutoff in serum units. It does not talk of whole blood units. So many a times, babies with congenital hypothyroidism are passed off as normal by the pediatrician who has attended the delivery and seen the baby for the first 2 days, because he does not look at the units in which the TSH is expressed. It is MIU per ml of whole blood unit or MIU per ml of serum units. So in India, we use a cutoff of 20 of serum units and not whole blood. If your card expresses it in whole blood, you need to multiply it by 2.2. And then a 12 becomes 25 and the baby needs to be called for confirmatory sampling. So this is something very, very important. There have been cases in the city of Mumbai where a value of whole blood unit has been passed off as normal and the babies come back 4 to 6 weeks later with blatant clinical signs of hypothyroidism. So when do we screen these babies? They are ideally screened after the first 48 hours. And why is it so? Because you want the physiologic surge of TSH to abate, or you might just catch a physiologically higher TSH value and label the baby erroneously as one required to be called for confirmatory testing. So screening must be done on day 3 or day 4 of life postnatally, and then clinicians often complain that we need to discharge them early. There are compulsions because of insurance or reimbursement that we can't keep them longer than 2 days. So we tell them, if you're sampling the baby between the 24th and the 48th hour of life, use a higher cutoff to recall the babies. The cutoff is 34, whereas if you're sampling the baby after the first 48 hours, the cutoff of TSH that you need to use to recall the baby is 20 MIU per ml in the first 2 weeks of life. After the first 2 weeks of life, it is around 10. So you need to be careful of these numbers. If you have done it between 24th to 48th hour of life, the cutoff of TSH is 34. And after 48 hours of life, in the first 2 weeks, the cutoff is 20. And after the first 2 weeks, if you're testing a baby, the cutoff is 10. If you want to be very precise and look at the standard deviations, the +2 standard deviation is 9.1. So a TSH of 9.6 or 9.7 would actually be deemed borderline higher, and the baby could be recalled for confirmatory testing. But for the masses, again, for convenience, we've put it at 10. You must repeat the screening in babies who have been born LBWs, VLBWs, preterms, sick terms, and twins, especially same-sex twins. Why is this? Because they could have a delayed rise of TSH. So NICU graduates who receive dopamine, glucocorticoid infusions may have suppression of the hypothalamo-pituitary axis, and they may not actually exhibit a rise in the TSH in the first 2 weeks. So this special set of babies has to be recalled after first 4 to 6 weeks for a repeat screening. So these graduates are specifically tagged a red dot on the file saying you need to come back for thyroid testing at anywhere between 4 to 6 weeks. So this is the uniform simplified algorithm that I like to use. It's very, very simple, and I always insist to my pediatrician and neonatologist colleagues to just have a copy on the table. It makes life very easy for them. So you do a heel prick, or in countries like ours where you are not going to screen for other inborn errors of metabolism, you could even use the cord blood. But please remember, you cannot screen for other inborn errors of metabolism by using the cord blood, because you haven't exposed the baby to feeding to generate metabolites. So if you want to use cord blood, you would have to use it only for primary congenital hypothyroidism, or you use the heel prick sample after the first 48 hours. So the rules are simple. If the TSH is less than 20, you would deem the baby to be normal and not worry about recalling the baby back for confirmatory testing, except if the baby belongs to the high risk setting, in which case you shall call the baby back. If the TSH is greater than 20, you have two things to look at. Is the TSH between 20 to 40, or is the TSH greater than 40? If the TSH is greater than 40, the probability of the baby having the disease is near certain. So you would immediately call the baby for a confirmatory venous sampling if the baby is older than 3 days. So you will not waste any further time. You will call the baby for a confirmatory venous sampling immediately if the baby has lived for 72 hours. Now, if the TSH is between 20 to 40, you will call the baby back for confirmatory sampling between the 7th to 10th day of life. Now, you will ask me why this? Everyone's running that we must detect and treat in time. Why are you calling these babies back on day 7 or day 10? Now, this is because there is an entity called immaturity of the hypothalamo-pituitary thyroid axis, and it is physiologic. So the TSH dies down by day 7 in term babies. So to avoid over-treating transient thyrotropinemia, the babies are left alone, and also by logarithmic relationships, it is understood that TSHs between 20 to 40 would not compromise the free T4 level, which actually crosses the blood-brain barrier, gets deiodinated to T3 and myelinates the baby's cerebral cortex. So these numbers have been derived by great validation by logarithmic equations, and we know if the TSH is between 20 to 40, the baby would not be dysfunctional with regards to the free thyroxine levels. So you can allow a week, call them back, and now when you call them back for confirmatory testing, please ensure you're doing a concomitant free T4 level. So if your TSH has dropped to below 20 and your free T4 level is more than 1.1 nanograms per deciliter, then this was just transient rise or immaturity of the hypothalamo-pituitary thyroid axis, and you will send the baby back home saying there's no congenital hypothyroidism here. If the TSH is still greater than 20 in the first 2 weeks of life or greater than 10 after the first 2 weeks of life with a free T4 less than 1.1, you will immediately initiate treatment because this baby has congenital hypothyroidism. Now whether the baby has dysgenesis, dyshormonogenesis, that we could evaluate, but we would not delay treatment for the want of etiologic stratification. And then comes the third group which pediatricians often encounter. The TSH is high, is more than 20 in the first 2 weeks, but the free T4 is normal. It's greater than 1.1. And like I told you, if your free T4 is greater than 1.1, your baby is receiving adequate thyroxine for myelination. So then what is done is a TSH is repeated again in 2 weeks' time to avoid over-treating transient thyrotrophinemia. But the caveat is the free T4 must be greater than 1.1. You can't, and that's why I said when you're doing confirmatory venous sampling, your free T4 accompanying the TSH is mandatory. Now, if your TSH is greater than 10 beyond the 3 weeks of life, because here a week went away, then you're calling the baby after 2 weeks. So by the third week, if the TSH is more than 10, you're going to start this baby on thyroxine. Because after the first 2 weeks of life, the cutoff of TSH changes from 20 to 10. It is technically 9.1, but I'm giving you simple numbers to take home. 20 in the first 2 weeks, 10 after the first 2 weeks. Now, if the TSH is 10, what do we do? In India, the Indian guideline says pass these babies off as normal. The European and the American guidelines differ here, and in practice the guidelines differ. We stratify this group of less than 10 into those less than 6 and those between 6 and 10. The ones between 6 and 10 are followed up, are subjected to anatomic ultrasounds or functional technetium scans because they can have a group of mild congenital hypothyroidism, and if we find TSH is between 6 and 10 and an anatomic or functional deviation on the investigation, we still treat these babies. But the MAS guideline says a TSH less than 10 beyond the first 2 weeks of life can be passed off as normal. But that doesn't happen in practice. We are very stringent. 6, less than 6 is passed off as normal. 6 to 10, we usually either follow up or evaluate by anatomic and functional studies. That's a technetium scan, a technetium 99 thyroid scan. If we see reduced or increased uptake, or if we see the lobes of the thyroid to be smaller or some thyroid ectopia, we generally go ahead and treat these babies even for the mild hypothyroidism. So dysgenesis and ectopia constitute nearly 85% of all cases of permanent congenital primary hypothyroidism, and dyshormonogenesis constitute the remaining. In countries like ours where we have consanguinity and small community breeding, the dyshormonogenesis is higher than what is published in Western literature. I would put it somewhere around 20%, 20 or 22%, whereas Western literature puts it at 15%. There is an entity called transient congenital hypothyroidism that pediatricians must be aware of. And as pediatricians, we must see whether the problem is isolated or is a part of a larger congenital malformation, or is the baby having the disease as a part of a syndromic condition. Now, we can't afford to miss these as pediatricians. So it's a very, very crowded slide. Don't worry about it. Only 2 things that you need to see. This group, a normal free T4, but an increased TSH, where I said you could call the baby back after 2 weeks. What are the likely causes? First one is delayed maturation of the hypothalamo-pituitary axis. So the HPT axis is immature. It takes time to adapt to external thermogenesis. It might take a week and the values may all be fine. But do not forget, the babies could have transient or mild forms of permanent congenital hypothyroidism. Babies with Down syndrome will often exhibit this pattern. and the very, very rare entity of thyroid hormone resistance can present with this in the neonatal period. And hence I have emphasized this box that when you see a high TSH, which is more than 20 in the first 2 weeks or more than 10 later, but a normal free T4, think of these 4 conditions and then call the baby back for a confirmatory testing in a couple of weeks. Now, look at the causes of transient hypothyroidism, where you would need to treat the baby in infancy, but the baby would get rid of the thyroxine as the baby grows older. Because the first question parents ask is, doctor, how long do we need to continue? And you must delineate the etiology to prognosticate and tell the parents that is the therapy for life or is the therapy for a predetermined time frame. So the causes of transient is the baby is being exposed to maternal TSH receptor antibodies. So the mother is a patient of Graves' disease. She has transmitted the blocking type of TSH receptor antibody to the baby, and the baby becomes functionally hypothyroid. Or the mother's been treated with propylthiouracil or carbimazole, these days carbimazole, and the baby develops transient hypothyroidism, requires treatment until 4 half-lives of the drug have elapsed, after which the baby does not need treatment. The commonest entity where the mother is healthy, does not have a thyroid disease of the hyperfunctioning type, but the baby develops transient hypothyroidism, is heterozygous mutations in the thyroid oxidase gene. So in we've had a publication where we published heterozygous mutations in thyroid oxidase genes are the commonest cause of actual transient hypothyroidism, not lab assay interference or lab variations or transient immaturity of the HPT axis, but where we've needed to treat the baby for the first 3 years, then the child could go off the thyroxine until puberty, and during puberty the child fell short again because one of the 2 copies of the thyroid oxidase is dysfunctional. So this is a mild form of dyshormonogenesis. Now in Bombay we do not encounter patients from endemic iodine deficiency, and in the era of iodized salt the incidence is definitely lesser. But what we do encounter is prenatal or postnatal exposure to iodides. So NICU graduates typically who are scrubbed with povidone iodine may demonstrate an entity called Wolff-Chaikoff effect. So it's functionally the thyroid goes into a state of functional inhibition because of the high iodide exposure. And once the thyroid resolves from that exposure, the baby does not need thyroxine any further. So if you have a baby who's lived in the NICU for a while and has been washed with povidone iodine day in and out, be careful and monitor the thyroid function again. So I'm not going to dwell into this crowded slide, but what I intend to let the audience know is 2 investigations are done to delineate dysgenesis, which is a structural dysfunction of the structural malformation of the thyroid gland, and dyshormonogenesis, where there is an insufficiency in one of the enzymes associated with hormonogenesis. So the investigations are very concomitant, that if there is dysgenesis, the ultrasound will show a smaller gland or no gland in agenesis or athyrosis, and the technetium 99 scintigraphy will show reduced or absent uptake. So they are very synchronous. So an experienced sonologist will tell you, I'm not able to see thyroid tissue properly, but still you do not trust him or her as it is with us doctors. So you send the baby for a technetium scan, and the nuclear medicine consultant calls back saying there's no tracer uptake. And the tracer uptake is compared to that of the salivary gland uptake. So if the baby has a complex congenital malformation or a syndrome where the salivary system too is affected, then the results are confounded. And in dyshormonogenesis, it is exactly the opposite. The sonologist says it looks like a neonatal goiter. The gland is trying to overfunction to meet up the requirement. And the nuclear medicine consultant says there is avid or increased uptake of the tracer in the baby's thyroid. So they have to be synchronous. Except one entity which is strange, and we have reported quite a few cases, is the first step in thyroid hormone synthesis, which is the sodium iodide co-transporter step, where the thyroid gland takes these 2 ions to form the colloid. And if you have a mutation there, the sonologist will say, I'm seeing an enlarged gland, and the nuclear medicine consultant will say there is no uptake. And then you will be in a fix to whom do I believe? Is this dysgenesis or dishormonogenesis? So it is invariably dishormonogenesis. The block is in the first step of thyroid hormone synthesis due to a sodium iodide co-transporter defect. This is how the images look. These are representative. This is how a normal gland looks in the baby. This is normal sized and increased uptake. There's a thyroid and salivary, thyroid and parotid ratio calculated, and that determines whether the uptake is increased or decreased. This is how dishormonogenesis looks. This is how dysgenesis looks. This is how athyrosis looks, like there's no uptake. This like absence of the thyroid gland. And here in this condition, if the mother has had a thyroid disease and has been poorly replaced in the first trimester, then in spite of timely detection and treatment, the baby will have some subtle neuromotor insufficiencies. Because in the first 12 weeks, the baby is completely athyrotic and dependent on the mother's thyroxine for replenishment. And this is how ectopia looks at the base of the tongue. So treatment varies between 5 to 15 micrograms. I haven't changed the number because the Indian guideline still says 10 to 15, but we need doses as low as 5 microgram per kg, and now the treatment doses are based on stratification using the free T4 levels. So if your free T4 levels are less than 5 picomoles per liter, you will use a higher dose spectrum range. If they are between 5 and 10, you will use a median dose spectrum range, and if it is more than 10, you will use a small dose spectrum range. You will not bombard the baby empirically because it causes tachycardia, sweating, anxiety, and we wouldn't want any of this happening. And the goal is to normalize the free T4 in the first 2 weeks and the TSH by a month and a half. So please do not chase the TSH levels very frequently in the first month. All you need to ensure is that the free T4 level has normalized. When I say normalized, is between the mean and +2 standard deviation for the age of the baby, and the TSH would normalize by the logarithmic equation by a month and a half. Treatment must be initiated as soon as possible, and again an important message is, if you do not have access to anatomic or functional studies, use the algorithm and start treatment for the baby, and do not delay treatment for the want of etiologic stratification. But for prognostication, one would have to do it, and levothyroxine tablets are crushed and administered via a small spoon in a few ml of either water or breast milk. So this is what is done yet in our country. There is a suspension now being studied, is in phase 3B. It is currently being studied at hospitals across the Middle East. It is a very concentrated suspension, almost having close to 150 micrograms of thyroxine in an ml. So the dosage is calibrated in drops. But it is only investigational currently and is given to a small section of patients. So I've been following some of these patients, but they are receiving the medication from their primary care hospitals in countries that they live. When they do come to India during the summer and the winter break, I happen to see them. So I know exactly how the titrations are done. But bioavailability of these suspensions is still to be ascertained before they become commercially available. But in times to come, we will have suspensions of thyroxine, of levothyroxine available commercially. So monitoring is free T4 at 2 weeks, TSH first at 1.5 months. In the first 6 months, you would monitor the TSH every 2 months. And until the third birthday, every 3 months, after which it could be done once in 6 months. But every time you make a dose change, please call the baby back in a couple of months and assess the adequacy of the replacement that you are providing. Now, in case you have not been able to evaluate the baby in infancy because of want of time or lack of investigations, and or if the baby was preterm or was an NICU graduate, re-evaluate them at 3 years. Do not miss the opportunity. It's called the assessment of permanency, especially when you've not been able to delineate whether the baby had dysgenesis or dishormonogenesis. Now, if the baby is athyrotic, you will not attempt this, it's not permissible. Or if there is severe dysgenesis or a genetically proven dishormonogenesis, you cannot do all of this. But if you didn't know what you treated, but you had to because of the numericals, at 3 years you can perform what is called as the assessment of permanency test. Now, outcomes. Now, in India, at least in the metropolitan cities, we don't talk of intellectual disability anymore in babies with congenital hypothyroidism, but I'm afraid I can't say that for the rest of the country, so we still have to talk about delayed psychomotor development. But we are fortunate we don't see any intellectual disability or mental retardation anymore in congenital hypothyroidism, except the syndromic ones, where there are transcription factor mutations in the cerebral cortex. Their replacement of thyroxine is not going to correct those. But what is focused or what is looked at more now is the subtle specific deficits in memory, attention and information processing, coordination response time, behavioral deviations like commonly ADHD, fine motor function deficits, very, very low decibel hearing and speech deficits. So this is what we are seeing in our cohort of more than 10,000 babies whom we are following up for the last 5 or now 7 years. These are the deficits that we are seeing. Their gross IQs are normal, they are academically very good, but they take time to respond in certain situations, may have a difficulty playing racket sports, or maybe when they grow older driving, we don't know about it. They may have very low decibel hearing impairments and certain speech deficits. And we are trying to figure out, because all these babies were screened, detected, treated on time. So it's not got to do with the lack or the late initiation of thyroxine, but probably common dysfunctions in the thyroid gland and either the vestibular canal, the cerebral cortex. We found answers for some because the semicircular canals also express these cotransporter and other iodide channels. So we know why some of them can't hear, and we know why some of them can have postural instability or vertigo. Similarly, we have isolated some transcription factors in the brain, and hence we know, so if you've had a severe dysgenetic gland, you might have some dysgenesis in the small parts of the cortex, which lead to these small neuromotor insufficiencies. The syndromic group of congenital hypothyroidism and ones with transcription factor mutations may not have the best of the prognosis in spite of timely detection and treatment. It all depends on which is the organ system involved other than the thyroid. So this is something that I love to do. We do a lot of genetic work, and we like to stratify all our babies with congenital hypothyroidism. And the simple message is, again the slide is crowded, but the simple messages are, most of your dysgenesis, thyroid malformation, structural, is sporadic. It's very less likely that you'll pick a mutation up. When I say very less likely, in our series we've picked pathogenic variants in about 12% of thyroid dysgenesis. And the commonest one in the non-syndromic forms are PAX8 and TSH receptor. So if you have a patient with thyroid dysgenesis who is not dysmorphic and does not have other congenital malformations, the likelihood of finding a genetic variant is only 12%. 88% is sporadic or idiopathic, which means we do not yet know why it occurs. It might be a developmental disruption syndrome. And amongst those 12%, the commonest ones in the non-syndromic ones are the TSH receptor mutation and the PAX8 mutation. Now, if this PAX8 is associated with a renal anomaly, then it falls into the syndromic group, though it will not affect your cognition otherwise. And if it is not associated with a renal anomaly, it would be classified as isolated. But amongst the dyshormonogenesis group, which is the red group, which is about 22% in India, 88% of the times you will pick a mutation. It is usually homozygous or heterozygous. 88% of the time you will pick up a mutation, and most of these are isolated and non-syndromic. The only one which is syndromic is the Pendred syndrome, which is taught to us from first MBBS. So the mutation in the Pendrin gene, hearing impairment and goiter. So that's the only syndromic dyshormonogenesis which is common. All the others are isolated. And the 4 which are rare but do not have very great prognosis in terms of association with other malformations are the NKX group of genes. These are transcription factors expressed in the thyroid, the lung and the brain. And that is what is called as the brain-heart-lung syndrome. So you have a mutation that causes developmental disruption of the thyroid and other midline structures of the body. And the commonest mutation in that rare syndromic group is the NKX group. But this is thyroid dysgenesis. Right? So last slide, I was speaking to the fetal medicine expert in the morning, and I thought it would be nice to just share what is done for antenatal treatment of fetal goiter. So first and foremost, all mums, all to-be mums must get 250 micrograms of iodine per day. That is very, very necessary. That's the first thing. Any woman who's had a history of thyroid disease would usually have an increase in the requirements of thyroxine in pregnancy, and she must be intensively monitored, especially the first 12 weeks, because the fetus is completely dependent on maternal thyroxine in the first 12 weeks. Now, fetal ultrasounds are performed between 22nd and 32nd weeks of gestation, and there are gestational cutoffs available for fetal thyroid diameter and fetal thyroid circumference. Now, if either or both, generally both, exceed the 95th percentile for that gestation age, then a fetal thyroid disorder is suspected. In such cases, what is done is a sample for free T4 and TSH of the fetus is obtained by chordocentesis. Please note, not by amniocentesis. Chordocentesis is a risky procedure, but diagnostic confirmation is only by chordocentesis. And if the biochemistry suggests and or if there is progressive hydramnios, then intraamniotic instillation of levothyroxine is done by the fetal medicine expert. And that reduces the fetal goiter, reduces the chances of fetal loss because of the disease. So this is something which is done in India, which is done at our center. So, and must not be missed. There are fetal losses because of undetected thyroid disease, and in the current era, every pregnancy is precious. So to sum up, universal screening for congenital hypothyroidism is the essential right of every neonate and not a luxury as thought of earlier. Appropriate timing, analytical parameters to be used, and cutoffs are very well defined now on. So there should not be any discordance or debate. We should all be on the same page and have consensus with regards to these. Approaches to assess etiology and severity are important, but must not delay initiation of treatment. Immediate initiation of appropriate thyroxine supplementation, periodic monitoring, and regular assessment of developmental and neurosensory functions constitute contemporary mandatory standard of care. So it's not optional for us to do neuropsychological assessments or involve a developmental pediatrician or do a BERA. It's all a part of mandated standard of care. Thank you very much, ladies and gentlemen. STM Manpur. So we'll move to something lighter now from the so this was the talk I did recently at the Pedicon at Hyderabad, the National Pedicon, and I'm taking the liberty to use the same slides because being at Dharwad is very informal for me. I feel like coming home, so I didn't make any new slides. So before we talk of refractory rickets, we must all know what constitutes adequate treatment of rickets, because the very purpose of identifying refractory is confounded when you have not adequately treated the rickets in the first place. So if the infant is less than 6 months of age, the dose requirement of vitamin D is 2000 international units per day for a period of 12 weeks. So I'm currently talking of only vitamin D deficiency rickets before I move to refractory. So the first and foremost thing when you're treating an infant less than 6 months, there is no role of weekly, fortnightly, monthly replacements. Indian Academy of Pediatrics does not allow it. So you will use 2000 international units of vitamin D every day for a period of 12 weeks and follow it up with a maintenance dose of 400 international units a day. Now next, if the baby is between 6 and 12 months of age, you are permitted to use equivalents of 2000 units a day on fortnightly or monthly basis. So either you use 2000 international units daily for a period of 3 months, or use fortnightly or monthly basis. So 30,000 units every fortnight can be given, but this is only after 6 months of age. And if the baby is older than a year, then you either use a 3000 international units daily, or what is preferred by the pediatricians is 60,000 units fortnightly for a total of 5 or at the most 6 doses. So we do not use larger doses in children less than 12 years of age. So now these guidelines hold very good until the 12th year of age. For adolescents, we have recently had an expert committee meeting and the paper is in publication. So I will share that with all of you when it is actually published. The guidelines are different and the doses are larger. So the existing Indian Academy Pediatrics guidelines hold very good until 12 years of age. After the onset of puberty, the requirement is higher, and hence the way rickets is treated or vitamin D deficiency is treated is going to be changed. And here the maintenance requirement is 600 international units per day. So we have introduced a concept in the new paper called as the estimated average requirement of vitamin D in infancy and subsequent to infancy. And it may vary anywhere between 400 to 600 international units per day depending on the region, your skin type, the sun exposure, the diet, the presence or absence of vitamin D rich foods in your diet, and also exigencies like illnesses, winters, puberty, other stress states. So there is also a recommendation now that children who've had vitamin D deficiency rickets or have had vitamin D deficiency requiring replacement of with therapeutic doses must be kept on maintenance. And then immediately the question is, how long do we continue the maintenance? The expert group of which I am a part of was very candid enough to say we do not know how long we need to give it. So we've mentioned that in the paper to come, that we do not know whether it's forever, but we need to give them maintenance doses because they're surely going to relapse if you don't do that. So we have evidence that we have to, but we do not know how long we need to. So we are practically like Abhimanyu there. We know we get into the Chakravyuh, but we do not know how to get out of it. So a calcium intake of 50 to 75 milligram per kg per day for the first 2 months is necessary while treating vitamin D deficiency rickets. So let me give you now some scenarios of refractory or resistant rickets. So this was a toddler with failure to thrive, short, hypotonic. You can see the standard deviation scores. Picture typical of vitamin or nutritional rickets or calcipenic rickets. Let me be more accurate. This picture was typical of calcipenic rickets. And he was treated with oral vitamin D3 supplements like everyone would do in the right doses. But at the end of 2 months, his alkaline phosphatase was still elevated. And we were forced to think that is this resistant rickets. So before thinking of an alternative etiology, you must rule out malabsorption. So what we actually like to do is look at the parathyroid. In this case it was elevated. That told us that the cause of calcipenia wasn't corrected, whatever it was. And the vitamin D level was still low in spite of replacement of adequate doses of vitamin D. So malabsorption was thought of and a parenteral dose of vitamin D3 was given, which led to remission of the rickets. So malabsorption is a commonly missed cause of resistant or refractory rickets. And then comes the question, how many units of vitamin D can we give parenterally? So a simple thumb rule is do not exceed 10,000 units per kg of vitamin D with a ceiling of 3 lakh units. Do not exceed 3 lakhs under any pretext, even if the kid is an older one. And the thumb rule is 10,000 international units per kg as a single dose. Now the question arises then, doctor, this is simpler to do. Jab the kid and send him home. The answer is no. Oral replacement is the preferred form of treatment of nutritional rickets. The results are faster, remission is better, and hence parenteral route is only reserved for cases with malabsorption. So this was nutritional rickets, malabsorption induced. Now let me delineate calcipenic and phosphopenic rickets. So all of the rickets needs to be delineated into two. So simply when we teach our postdocs, we tell them the louder rickets is calcipenic, the quieter rickets is phosphopenic. So if you have muscle weakness, which means delayed walking, hypotonia, pains, like Papa press my legs in the night, or Mama press my legs in the night. These days it's papas who are pressing the legs. So tetany, enamel hypoplasia or osteopenia, the rickets is more likely to be calcipenic. Whereas if the rickets is quieter, it preferentially involves the lower limbs, and on X-ray the bones don't look as rarefacted as they should in rickets, then it's more likely phosphopenic. So there are dense bones in phosphopenic and the rickets is quiet. The patients only come for deformity. So the investigations that we do in children with rickets, first all of us are taught calcium, phosphorus, alkaline phosphatase. Please add a creatinine in the first line investigation. The next investigation amongst the first line is 25 hydroxy vitamin D level. That reflects the actual stores of vitamin D in the body. So that should be our first line investigation. Then if your rickets has not healed, or if you feel this is a relapse or not the first presentation, you will include parathyroid hormone and 125 dihydroxy vitamin D levels. Now 125 may not always be feasible to do. It has an extremely short half-life, and hence if the assay is not run in-house, it is not very wise to transport it to a place 2 or 3 hours away and expect that the result would be accurate. So at least a parathyroid hormone, if it is elevated, it more or less confirms the rickets is calcipenic. And if it is elevated in spite of supplementing vitamin D3, you know the patient requires an active form of vitamin D3, and you know you're dealing with the VDDR group. So it sort of clinches the diagnosis. The third line is when rickets does not respond to calcipenic supplements, is your blood gases, electrolytes and urine pH to rule out renal tubular acidosis. But many a times the history and the appearance is very striking. Children with RTAs are often polyuric, polydipsic, they have hypokalemia, so they would exhibit manifestations of those, and we generally need not follow this sequence always in an algorithmic fashion. The assessment is guided by the clinical presentation. So this was a 7-year-old who presented only with bored legs. Like I told you, she had no other complaints. She had not much of bone pain. She had no enamel hypoplasia. She had no tetany. The mother was only concerned that she's a girl and she has bored legs, you correct it. So she had very mild rachitic rosary, disproportionate to the varus deformity that she showed. That told us that there is preferential lower limb involvement. Not that these patients will not have rosary, they will, but it would be milder as compared to the lower limb involvement. So we evaluated her. Calcium was 9, normal. Alkaline phosphatase elevated. Anything more than 450 international units is elevated pre-pubertally. Low phosphate levels. Now phosphate levels differ by age. In infancy, phosphorus levels up to 7 are considered normal. So you must get to meta, check the range of phosphorus before you label someone as phosphopenic or hypophosphatemic. Phosphorus was low here for age. Creatinine was normal. Vitamin D levels were okay. And strangely, the PTH was normal. So a higher alkaline phosphatase with a normal PTH told us that this was not involving the calcium axis. This was not calcipenic rickets, this was phosphopenic. So what did we do to confirm this? We went ahead and did the urinary spot phosphate and creatinine, calculated the tubular reabsorption of phosphate, which was lesser than the usual 88%. That told us that she was losing phosphate in the urine, and we looked at the TMP GFR, which was only 2, and the diagnosis of hypophosphatemic rickets was confirmed. Now the story doesn't end here. Hypophosphatemic rickets is a family. It could be X-linked, which is FGF23 induced, a phosphotonin which drives phosphorus out of the renal tubule. It could be autosomal dominant or autosomal recessive, and could have a variant associated with hypercalciuria. And if you have hypercalciuria, you will not replace these patients with active vitamin D analogs. So the treatment is phosphate supplements, and as soon as you start phosphate, the PTH starts to rise. And then you have to introduce active vitamin D analogs. But you can't do that in hypercalciuric patients, otherwise you will precipitate nephrocalcinosis. So stratification, both biochemically and genetically, is important. And often phosphopenic rickets could be a part of generalized tubular dysfunction like a proximal RTA or McCune-Albright syndrome, or could be an oncologic osteomalacia. So do not close the file after making the diagnosis of phosphopenic rickets, prescribing some Adphos sachets or other phosphate supplements and saying your job's done. Keep calling them back and evaluate them till you've confirmed the molecular etiology of the condition. 15 years old girl, now very sorry state. Everyone thought she had rickets, but an important history was missed. She had a low hemoglobin of 8.6. So anemia, rickets, she also had polyuria, which had developed after, much later after the anemia. So a simple investigation like creatinine was missed in the first phase. She had a creat of 3.7. So this was actually renal osteodystrophy and not rickets, but referred as rickets. I mean, we would treat her like that. So here these patients require active vitamin D3 analogs because the renal parenchyma fails to secrete 1-alpha hydroxylase, which leads to conversion of 25-OHD to 125-OHD. So they need to be treated with calcitriol in addition to calcium and phosphate binders in many cases. Now, this scenario, 5 years old girl, multiple presentations with delayed walking, hypocalcemia, depicted delayed dentition. The teeth which were there depicted enamel hypoplasia. So we knew immediately this was calcipenic, but the girl had multiple presentations. So she had received vitamin D for 5 weeks, 6 weeks, 8 weeks, 12 weeks, and then she would come back again. So this told us that this was one of the resistant forms of calcipenic rickets. So in such cases, the investigations that need to be done are PTH. So if your vitamin D is in the toxic range and your PTH is still elevated, it tells us that either the vitamin D is not getting converted to the active form or the receptor is not accepting the active form of vitamin D. So her 125 dihydroxy vitamin D3 levels were done, which were undetectable, and a diagnosis of 1-alpha hydroxylase deficiency was made. The patient was started on active vitamin D3 analogs and the rickets went into remission. Now the last subtype, now this is something very striking. These are spotters. So bald children coming with rickets or alopecia ricket and all signs of calcipenic rickets is nothing but vitamin D resistant rickets type 2. Here the receptor is at fault, and whatever you might do, these patients will keep coming back with hypocalcemia. What we like to do for them in the first visit is segregate whether the mutation lies in the DNA binding domain of the vitamin D receptor or the ligand binding domain of the vitamin D receptor. If it's the DNA binding domain, the hypocalcemia is near refractory. We almost have to have chemoports in them and keep giving them IV calcium on regular outpatient basis. If the mutation is in the ligand binding domain, the disease quietens as they reach puberty. When I say quieten, they don't have best of the teeth. They invariably have deformities. They are invariably bald, but they do live. So, so it's very, very important in the current clinical and medico-legal era to stratify these vitamin D resistant rickets type 2 into those having a mutation in the DNA binding domain versus those in the ligand binding domain. And they're treated with extremely high levels of active vitamin D3, oral calcium almost to the tune of 2 grams per day, and invariably have chemoports or lines to receive IV calcium on outpatient basis. This is how the X-ray looked. And you can see here the 125 hydroxy vitamin D was more than what the assay could measure, but the child was still calcipenic. That told us that the receptor was dysfunctional. This is a child with RTA, so short, polyuric, hypokalemic, nephrocalcinosis on the ultrasound, distal RTA is the diagnosis. So refractory rickets is classified into calcipenic, phosphopenic, and that associated with acidosis. The calcipenic group is your simple vitamin D deficiency or 1-alpha hydroxylase deficiency or dysfunction of the vitamin D receptor. The phosphopenic group that I told you could be X-linked, autosomal dominant, autosomal recessive, one associated with hypercalciuria, Fanconi syndrome, McCune-Albright syndrome, or one associated with oncologic osteomalacia. Acidosis, typically proximal, distal, or type 4, which is again then usually renal or adrenal. So when to look for resistant rickets? First is no therapeutic response to vitamin D and calcium. Or if your patient exhibits enamel hypoplasia, pathologic fractures, has refractory hypocalcemia, alopecia, do not wait for therapeutic response to a course of vitamin D. Straight away start evaluating them for refractory rickets. Or if the child exhibits relative sparing of the upper limbs and chest, lack of hypotonia and dense bones, it's usually phosphopenic rickets. Or if the child has polyuria, hypokalemia, failure to thrive, nephrocalcinosis, think of RTA. So I'm not going to dwell into this crowded slide, but I need you to look at one parameter each. In your chronic renal insufficiency, the phosphorus is going to be higher. So one investigation in every condition will tell you what the diagnosis is. So in chronic kidney disease related renal osteodystrophy, the phosphate levels are higher. None of the other rickets have high phosphorus levels. So it sort of clinches the diagnosis. Next, in hypophosphatemic rickets, the parathyroid is always normal before initiation of treatment. In renal tubular acidosis, you will invariably have hypercalciuria, the distal, and your blood gas will depict acidosis and urine pH will help stratify it into proximal versus distal. In VDDR, that is your refractory vitamin D related rickets, your parathyroid will always be high in spite of having normal vitamin D levels. So one investigation in each condition helps you clinch the diagnosis. And lastly, not all bowing is rickets. So if you only see bowing and do not see the other markers like fraying, cupping, splaying, think of conditions other than rickets. The bowing could be congenital, the bowing could be developmental, the bowing could be due to Blount's disease, it could be fibrocartilaginous dysplasia, it could be skeletal dysplasia. If the child has cafe au lait and fibromas, it could be neurofibromatosis. So do not think of only rickets, especially when the radiology is atypical. Now look at the bones there, they are bent, there is tibial angulation, but there are no any other signs of rickets. So not all bowing is rickets. Thank you very much, ladies and gentlemen. Any questions? No, they can ask. Feel free to ask.
Anybody? How common do you see thyroid dysgenesis and all? Very common. 85% you told
Commonest
is
cause of
commonest
congenital
cause.
hypothyroidism is dysgenesis. Dysgenesis is quite variable. And you need a very good sonologist to tell us that the lobes of the thyroid and the isthmus are smaller for the age of the child. That is how we get to the diagnosis of dysgenesis. And as I mentioned earlier, only 12% of these have an underlying genetic basis. So 88% of the times it's a developmental disruption.
Correct. So what about the secondary hypothyroidism? How do you clinically, what would be the outcome?
Yes, so that's a good question. Now, secondary hypothyroidism is generally or is commonly associated as a part of panhypopituitarism. So the presentations and references usually are from the NICU for either hypoglycemia because of concomitant growth hormone and ACTH deficiency, or micropenis, or midline defects. So the common presentation of central hypothyroidism is a part of the multiple pituitary hormone deficiency syndrome complex, but you can also have central and tertiary hypothyroidism in isolation, but it is rare, and the biochemical presentation is a low free thyroid hormone level and a normal or inadequately compensated rise in the TSH. So you have a frankly low free T4 level, generally less than 0.8 nanograms per deciliter and usually 0.5, 0.6 in severe cases, and the TSH is unable to mount a compensatory rise. So you have low thyroxine from the gland, but a dysfunction either in the TRH or the TSH, and hence the levels are either low, normal, or up to 10 MIU per ml, and that alerts us that the hypothyroidism is central and not primary. And here the important message is you must rule out concomitant adrenal insufficiency. First start the baby on hydrocortisone if the baby is insufficient, and then start thyroxine. Otherwise you trigger a crisis by starting thyroxine first.
I have a question. We had a baby with sort of tertiary hypothyroidism, hemangioendothelioma of liver. How to monitor thyroid profile in growth in such babies? Basically, we had a huge liver, so the child was not thriving well, but it was just based on investigation. He had a high TSH, but FTO4 was near normal or below normal.
No, so what you are talking about essentially is a condition called consumptive hypothyroidism. So patients with hemangiomas or hemangioendotheliomas of the liver often present with an entity called consumptive hypothyroidism. The same thing is also seen in patients on multiple anti-epileptic drugs. So there, even if you do not have an inherent thyroid disease or an HPT axis dysfunction, you will initiate these babies on thyroxine. Always attempt to maintain the TSH to below 4.5 and maintain the free T4 between the mean and +2 standard deviation for the age, and if the other systemic comorbidities exist, anywhere around the +1 standard deviation for the age. So this group of consumptive hypothyroidism stems from hemangiomas or hemangioendotheliomas of the liver, anti-epileptic drugs, usually multiple, or other enzyme inducing drugs. They cause accelerated metabolism of the thyroxine. So your requirements tend to be higher than what is conventionally published in textbooks.
Like many of the valproic acid induced, we are seeing of late higher TSH. So in those cases, is it better to shift them onto other anti-epileptics, or should we go on supplementing with
so generally we tell neurologists that it's best to treat with what you wish to treat, and we take care of the thyroid disease rather than asking for a change in the anti-epileptics. So the treatment protocol is guided by the neurologist based on the clinical and EEG response, and even subclinical hypothyroidism, which is values of TSH between 5.5 above 5.5 with normal free T4 levels, it is recommended to treat them in patients on multiple anti-epileptic drugs.
Many times I have seen the sodium valproate induced endocrinopathy, no, sir. So once we taper and stop and put an alternative, they come normal after a month.
So they can be discontinued.
Yeah. So in that situation, whether we need to treat with thyronorm for transient period or we may not.
No, so it all depends. Now, if your TSH is between 5.5 and 10, and your free T4 levels are well compensated, then we would differ. The world would differ, has two schools of thoughts. In patients with subclinical hypothyroidism who are otherwise normal and the free T4 levels are well compensated, one may choose to monitor until the TSH reaches closer to 10 or beyond, in which case thyroxine replacement is initiated irrespective. So with TSH levels at or above 10, you must treat, even if the free T4 levels are normal.
So if the TSH is say 8 or 9, then we may not treat. If it is
you
above
may
10,
not, you may not, provided the child does not have any other comorbidities.
Okay.
Like say for example, if the child has autoimmune diabetes, or if the child has a syndromic
etiology.
But that we will evaluate only after tapering this sodium valproate we added,
Yes.
and then if it doesn't come to normal, then we will think of all those
yes.
things.
But on sodium valproate or multiple anti-epileptic drugs, if your TSH usually rises to above 10 by enzyme induction or consumptive etiology, it is generally recommended to treat these children.
Okay. One more thing is
Also the age of the child would be very important. So in the first 3 years, you do not have a choice but to treat.
yeah.
And during puberty, again, you do not have a choice but to treat. It's only beyond 3 until onset of puberty where you would look at multiple variables and then take a call.
So if we try to if we have initiated, till when we will give?
So until your primary offending agent is on. Once it's withdrawn, you will perform an assessment of permanency test.
One more thing, you mentioned that during the first trimester the baby is completely dependent. So have you seen any child, the mother was hypothyroid from initial of the pregnancy? How manifestation is different from the congenital hypothyroidism
No,
in those
so
group
yeah,
of children?
so the screening protocol for these babies does not change. And the presentation, the protocol of screening, confirmatory testing, diagnosis, treatment is exactly similar.
No, in that situation, the fetus has already started producing the thyroxine by itself. So after birth, the child will not manifest, or the TSH will be normal only.
Normal.
But how is the manifestation of the child? How
So
in the
yes,
sense clinically?
so these children may exhibit subtle neuromotor insufficiencies. Now if the baby does not have hypothyroidism, either primary or secondary, and it was only the mother who was untreated in the first trimester, the baby will not exhibit any signs at birth. Only as the baby grows older, you may see subtle neuromotor insufficiencies, could be ADHD, could be specific learning difficulty, and certain behavioral deviations.
Thank you, sir.
Thank you. Any more questions? Thank you.
Thank you for the insightful and engaging talk on endocrinology. Your expertise and clear explanation truly enriched our understanding of this complex field, sir. Thank you, sir. We'll hold the inauguration ceremony in a while. It gives me great pleasure to inaugurate the CME on Paediatric Endocrinology, a vital step towards advancing our understanding and care for children with endocrine disorders. Now I call upon our chief guest, Dr. Niranjan Kumar Sir, who is a Vice Chancellor, SDM Medical College and Hospital. He is a renowned plastic surgeon known for his expertise in cosmetic and reconstructive surgery. He is committed to enhancing patient confidence through safe, innovative and high quality care. We welcome you, sir. Now it's time to welcome our guest of honor on the dais. Dr. Sidhu Chakri sir, Secretary, IAP Karnataka State Branch 2025. We welcome you, sir. Dr. Veeranna Mudol sir, President, IAP Dharwad District Branch. Dr. Martandappa sir, Secretary, IAP Dharwad District Branch. We welcome you, sir. Dr. S.V. Patil sir, President, IAP Karnataka in his absence. Dr. Vijay Kulkarni sir, our beloved HOD, Vice Principal, Organizing Chairman on the dais. We welcome you, sir. I call upon Dr. Kavita ma'am to welcome our Niranjan Patil sir. Thank you, ma'am. I request Dr. Punima ma'am to welcome Dr. Sidhu Chakri sir. Thank you, ma'am. I call upon Dr. Samya ma'am to welcome Dr. Veeranna Mudol sir. Thank you, ma'am. I call upon Dr. Divya ma'am to welcome our HOD sir. Thank you, ma'am. I request our beloved HOD sir, Dr. Vijay Kulkarni sir, to address the gathering.
Good morning, one and all. Blessings of Lord Manjunath Swami and blessings of Puja Hegde sir. It's such a nice occasion. On this day, I am addressing you. Pediatric endocrinology CME is an important part of our day-to-day life, especially the cases we see, the approach what we have, and the endocrinologists who have come here, they make it so simple. It is like mathematics. And sometimes I feel it is so tough to diagnose when we are sitting in the OPD. With such wisdom from the speakers who have come today, from Abhishek from Mumbai and Dr. Shaila, and unfortunately Dr. Ganesh had to come from Delhi. He met with an accident yesterday, so he could not make it to today morning flight. So we'll really miss Dr. Ganesh. He is also a renowned endocrinologist practicing in Delhi. So, and for this grand occasion, for this pediatric endocrinology, this is the second year where we are having in successive attempts. So the main purpose of this endocrine CME is basically to strengthen the postgraduate knowledge and the practicing pediatricians, how relevant it is to be updated, especially when we are treating with congenital hypothyroidism. We had a guest lecture today morning on congenital hypothyroidism. Why it has come in the screening program, it is so important, and the guidelines keeps on changing. there is always a clash of European guidelines and Indian guidelines, and Abhishek made it so simple today and how we need to pick them up. I'm really thankful for the speakers, Abhishek and Shaila, to have made it today. And I'm ever grateful to our Honorable Vice Chancellor, sir. Papa, there is not even a day where he has not come to the hospital. So I warmly thank you, sir, for your enchanting contribution. And to just tell you, whatever we are in SDM Medical College, this campus, now we are a university, it is all because of untiring efforts of our Niranjan, sir. Hats off to you, sir, for your unwavering efforts and your commitment for the medical education. And I thank the IIP office bearers, Veeranna and Marthandappa, for shouldering our responsibility, always being supportive to us in holding the CME. And I wish all the delegates learn a few things from you. And we also thank the media team for giving us a YouTube link, so that anytime when we are free we can go through the slides. I wish you all the best, a happy learning. Thank you so much.
Thank you, sir. Today we gather with heart full of hopes and gratitude. As we begin this special occasion, let us invite divine blessing through a song of invocation by Dr. Bhagyashri. This song will help center our minds, uplift our spirit, and create a sacred space. Let its melody guide us into celebrating unity and peace and purpose.
जय गणेश जय गणेश जय गणेश पाहि मां जय गणेश जय गणेश जय गणेश रक्ष मां जय गणेश जय गणेश जय गणेश पाहि मां जय गणेश जय गणेश जय गणेश रक्ष मां मुदाकरात्तमोदकं सदा विमुक्तिसाधकं कलाधरावसन्तकं विलासिलोकरञ्जकम् अनायकैकनायकं विनाशिते बदैत्यकं नताशुभाशुनाशकं नमामि तं विनायकम् जय गणेश जय गणेश जय गणेश पाहि मां जय गणेश जय गणेश जय गणेश रक्ष मां जय गणेश जय गणेश जय गणेश पाहि मां जय गणेश जय गणेश जय गणेश रक्ष मां जय गणेश रक्ष मां जय गणेश रक्ष मां
Thank you, Dr. Bhagya, for this beautiful invocation song that set a serene and graceful tone for the event. Lighting the lamp is a symbol of wisdom, knowledge, and this dispelling of darkness. As we ignite the flame, we invoke positivity, enlightenment, and auspicious beginning. This sacred tradition makes the start of our event with purity and purpose. Let this light guide us throughout the event. Thank you. I hereby call Dr. Lakshmi, Pediatric Resident, for introduction and felicitation of our speakers.
Good morning, everyone. It's an honor to introduce our beloved delegates, Dr. Abhishek Kulkarni, sir, Associate Professor and Senior Consultant in Pediatric and Adolescent Endocrinology at HN Reliance Foundation Hospital and SRCC Children's Hospital, Mumbai. With nearly 20 years of distinguished clinical, academical, and research expertise, Dr. Kulkarni leads two of the busiest pediatric endocrinology units in Mumbai. He also directs the fellowship program at these premier institutes, shaping the next generation pediatric endocrinology in India. Sir actively participates in clinical research, serves as an international collaborator for genetics of obesity UK project, is a member of prestigious international consortium focused on rare genetic endocrine disorders such as congenital hyperinsulinism, neonatal diabetes mellitus, and monocarboxylate transporter 8 deficiency. In addition to this, Sir is the Chief Scientific Advisor to the Pediatric Endocrinology Evaluation and Recommendation Module of India and expert panelist on vitamin D supplementation guidelines for adolescents. Dr. Kulkarni has been honored with prestigious fellowship of Royal College of Child Health and Pediatrics, London. Title of Honorary Adjunct Associate Professor by Apollo Hospital Educational and Research Foundation, India. Now, I would like to request our Vice Chancellor, Dr. Niranjan Sir, to felicitate Dr. Abhishek Kulkarni Sir. Gorilla. Now I request Dr. Shaila Pachapure ma'am to come on the dais. Ma'am is an accomplished assistant professor and consultant pediatric and adolescent endocrinologist. She holds MBBS MD in pediatrics and fellowship in pediatrics and adolescent endocrinology. Ma'am is affiliated with Department of Pediatrics at JNMC and KLS Dr. Prabhakar Kori Hospital in Belgavi. Ma'am is an active member of Indian Society of Pediatrics and Adolescent Endocrinology, serves an executive board member of Pediatric Adolescent Endocrinology Association of India. Currently, she is BAP secretary. Ma'am is faculty member at various regional and state conferences where she shares her expertise and passion for advancing pediatric endocrine. Thank you, sir. Now I request Dr. Niranjan sir, Dr. Vijay Kulkarni sir, Dr. Veeranna Mudol sir and Marthandappa sir to felicitate Dr. Sidhu Charki sir, Secretary IAP, Karnataka State Branch. Thank you, sir. Now, I request Dr. Veeranna Mudol sir and Dr. Marthandappa sir to give memento to our Vice Chancellor, Dr. Niranjan sir. Now I request Dr. Abhishek Kulkarni sir to address the gathering.
Good morning, friends, again. So as I mentioned earlier, it's always more than science coming back to Dharwad. It's an emotional connect.
and I'm grateful to the Vice Chancellor Niranjan sir and Professor Vijay Kulkarni for having me here. It almost feels like a homecoming to me every time I'm here because I was born in this city. And it's very heartening to see the way the pediatric department at the SDM Medical University now is being developed. In the morning, I just took a round with sir, and he was kind enough to show me a child admitted with diabetic ketoacidosis. And I was quite pleasantly, not just surprised, but was very happy to understand that the standard management protocols including assessment and provision of insulin are being followed, and they're just contemporary. The standard of care that is being provided to children here is contemporary and in lines with the best across the world. So I'm very delighted to be here, and I'm glad I could contribute by speaking on two simple or not so simple topics and try to make them as simple as I could. And I just hope and pray that my association with the university strengthens only further, and also this part of the world, because wherever I may be, my heart would always belong to this place. And as I said, I was born here. My grandfather was a teacher at the K Boards High School. So from being the grandson of a teacher at K Boards High School to attaining a near director position at two of the leading hospitals in Mumbai has been a very fruitful and very fascinating journey. And it wouldn't have been possible without the blessings of the elders here, in addition to the work and blessings of the Almighty. So thank you very much for having me here, and I only look forward to coming back again and again and again. Thank you.
Thank you, sir. Now I request Dr. Sidhu Charkey, sir, to talk a few words.
Good morning, one and all. I bring greetings from IIB Karnataka State Branch. Respected Dr. Niranjan Kumar sir, Vice Chancellor, Dr. Virana Mudod, President IIB Karnataka State Branch, Dr. Marthandappa, Dr. Devraj Raichur sir, and our beloved Vijay Kulkarni sir. We usually call sir as VK. I would like to share that with you, and most of you know that. And whenever we end up saying VK sir has called, or call comes, we immediately think something is going to be happening in or around in terms of academics also and fun. And I'm really happy that this CME has been happening constantly, because I have been witness for that. CME in endocrinology is necessary every year. Abhishek, I think you'll agree with me on this, because everything you bring us new updates. And hypothyroidism being a very ancient topic, we have new things to learn for all of us, for that matter. And thank you, sir, for inviting IIB Karnataka State Branch to be a part of this prestigious CME of endocrinology. At the same time, I invite you all. We at IIP Vijaypura District Branch is going to organize South Zone Pedicon 2025 in the month of November 21, 22, 23. And Abhishek, I'll send an invite to you, and definitely you can visit us. So I request all the dignitaries on the dais and off the dais and our postgraduates to be a part of this South Zone Pedicon, where you will have the opportunity to present your papers. Definitely listen to renowned experts across the globe, and we are trying to reach and make it possible in a big way under the guidance and supervision of all our senior IAPNs, including VK sir. Thank you, sir. Thank you for having me here.
Thank you, sir. Now, I would like to call Dr. Virana Mudol, sir, President IIP Dharwad branch, to deliver a vote of thanks.
Good morning, everyone. I would like to say that IIP Dharwad branch is involved as from the beginning into the academics this year also, and this is our 6th academic event of this current year, and with the help of both the medical colleges and all the support of private pediatricians, we would like to continue this feasts in the coming days also. I would like to thank Dr. Niranjan Kumar sir, being a busy schedule all the working days also. Just on one request, he agreed to come on a Sunday also and grace the occasion. And in his presence, this event gets even better recognition, and we hope his support and gracings will always continue for our IP branch. I would like to thank Dr. Sidhu Charkey. Though Dr. S.V. Patil was supposed to be here on this day, but because of some issues with his wife health, he could not attend. I would like to thank you both, sir, being supportive of our district branch from the state branch, and to both the speakers, and of course in absentia to Dr. Ganesh also, to Abhishek and Dr. Shaila, I would like to thank from our organization. And there is no special thanks needed for the Dr. Vijay Kulkarni, because he is part and parcel of the IIP, and he has attained a sort of a fatherly figure. So it is, I think, is part of his duty only, and I hope he'll continue to do this. And I'll thank all the postgraduates and the Sanofi company for organizing this event. Thank you.
Thank you, sir. Now please join us for refreshing tea break. We'll resume the CME after 10 minutes. So good morning everyone. So at the outset I thank Dr. Niranjan Kumar sir, VK Kulkarni sir. It's pleasure to be back to SDM and that feeling of coming back to the your journey where it started actually. So if we can go, 1 second, I'll just go through the things. Yes sir, 1 second. It is not in that. ಇಲ್ಲ ಸರ್ ಒಂದು ಜಸ್ಟ್ ಹಾಂ ದಿಸ್ ಐ ವಾಂಟೆಡ್ ಲೈಟ್ ಆಫ್ ಮಾಡ್ತೀರಾ ಸೊ ಬಿಫೋರ್ ಐ ಇಟ್ಸ್ ನಾಟ್ ಕಮಿಂಗ್ ದ ಪ್ರೀವಿಯಸ್ ಸ್ಲೈಡ್ ಹೈಡ್ ಮಾಡಿ ತೆಗೀರಿ ಅದು ಹೈಡ್ ಆಗಿದೆ ತೆಗೀರದನ್ನು ಮೇಲಿಂದು ಅದ್ರ ಮೇಲಿಂದು ಹಾಂ ಸೊ ಬಿಫೋರ್ ಐ ಗೋ ಟು ದ ಟಾಪಿಕ್ ಆನ್ CAH I just want to show the pictures of the genitalia, how the baby presents at various ages. Hide, unhide matter. So Akshay sir is well versed with these cases. He's been dealing with the cases of both XX DSD and XY DSD. We are now also in association with, like, we are getting a lot of cases of both male and female DSDs. Okay. So can make out the genitalia at various. This is presented at birth. You can make out the presentation at birth. It was like it looks like a male genitalia, but all of them are females. And here all of them are males, but because they had gonads in their region. So I'll come to this PPT later. So we'll go to the CH presentation. Actually this topic was supposed to be covered by Dr. Ganesh Javlikar sir, and it is his PPT. I owe this to him. So we are going to deal with the CH. So at the outset we outline, we'll discuss about the adrenal gland, steroidogenesis, what is the CAH and its types, and case scenarios. So adrenal gland, we all know that it is located above the kidneys, and we know that there are 3 layers, GFR. So GFR, glomerulus layer, which produces mineralocorticoid. So for the benefit of PGs, don't remember that G and G doesn't go hand in hand. So glomerulus layer and mineralocorticoid, fasciculata and glucocorticoid, and the fasciculata layer is the biggest layer, and reticular is for the sex steroids. This is the 3 layers, and the first glucocorticoid and the reticularis layer is controlled by the ACTH. The aldosterone level, the aldosterone axis is not under the control of ACTH. It is under the control of sodium and the potassium layer. It is the RAS system which takes care of the mineralocorticoid axis. So I think PGs you should be knowing about this pathway, but even though I want to say that when I joined my fellowship, when I asked my senior, he told first to write this pathway, then we'll discuss about the further thing. So to write this pathway, we should be knowing what are the words which are used here. So it starts from the cholesterol. All these of them are sex steroids. Sorry for my voice little bit, I'm down with my voice. So it's a cholesterol which enters the pathway, and we know that this is the glomerulus layer, this is the F layer, and this is the R layer. In the G layer, we know aldosterone is produced, cortisol is produced, and sex steroids are produced. Here the enzymes start with pregnenolone, and this is 11 hydroxylase enzyme. Here for the PG sake, it is 3 beta 2. When you split 3, it comes as 2 1. Next comes the 21 hydroxylase. When you split 2, it comes 11. So remember like that. First is a 3 beta hydroxylase, HST deficiency, then comes a 21 hydroxylase, then comes the 11 beta hydroxylase enzymes. So we'll not go further into this pathway. What I want to say here is, when this pathway is blocked because of the enzyme deficiency of 3 beta and 21 hydroxylase, the precursor channelized to this pathway, and they produce more of male hormones in the females. That causes virilization. This is a newer pathway, we'll skip this path. Okay. So CH, it is an autosomal recessive conditions, occurs in 1 in 10,000 to 1 in 15,000 live births, and the most common is 21 hydroxylase deficiency. Other types are there which are less common and will not be discussing about that. The types of CAH, PGs may be aware, there's something called as classical pathway, non-classical. In the classical, we have salt wasting. The child comes in crisis, it comes in shock. Then we have something in the older age, it comes just with the virilization. And then the later ages, it comes in the adolescent during puberty with the hirsutism, means the child comes with the signs of virilization. So it is just like it is not that one compartment is strict to only for salt wasting and all that. It's just a continuum of the disease. At one end we have a classical CH, at the other end we have non-classical CH. And most of them come in the salt wasting crisis. So what happens here is, if you look at the pathway, 21 hydroxylase deficiency is there. We don't get aldosterone, we don't get cortisol. So aldosterone deficiency comes with salt wasting. So it comes with hyponatremia and hyperkalemia. That is the investigation we get on the things. When we have a cortisol deficiency, we get hypoglycemia and hyponatremia. Hyperkalemia doesn't come in the cortisol deficiency, and they come with a failure to thrive. And we know that cortisol is the one which is having a negative feedback at the center. So whenever cortisol is deficient, there will be no negative feedback at the center, so ACTH will increase. That causes the pigmentation. It's not the aldosterone deficiency. So when these are not there, there is a channelization of the precursors towards the reticularis layer, and they produce more of androgens. That causes the virilization in the females. So if the enzyme deficiency is complete, they come in salt wasting. When their enzyme is nothing, like less than 1%, they come in salt wasting. If the enzyme is preserved, they come with simple virilization. That's it. They'll never come in the salt wasting crisis. So this is the gene pathway. We'll skip this pathway. So clinical features varies as per the age. The first picture which I had put, the apparently looking like a male-like genitalia with a clitoromegaly, and we use a gender-neutral term phallus. We don't use clitoromegaly or penile increase. We use a gender-neutral term, that is phallus. Phallus is increased, and we have to measure the length. How much is the length? And we look for the gonads, whether gonads are palpable or not, how many openings are there, and what is the situation of the labial fold. We call it as a labioscrotal fold. So that one, how it presents in the newborn period is, it presents as an apparent male with a bilateral cryptorchism. Many of the kids were reared as a male. Only when they come in salt wasting crisis at 3rd week or 4th week of life, they were diagnosed to have, they were female. Till that time they were thinking it is a male child. So next one is, but how the male present is, male kids present with the normal genitalia, but they present with a shock in later age, because in the pathway which we have seen here, we can make out that if this is deficient, more of male hormones is coming. That causes only virilization in the girls, but that doesn't cause any virilization in the newborn babies. It can cause virilization later in life. So that's why males come with the normal genitalia, especially only 21 hydroxylase I am talking. I am not discussing about the other conditions. So males come with the normal genitalia with a shock at 3rd or 4th week of life, but females come with the abnormal genitalia at birth. If picked up, we can treat early. If not picked up, they can come in shock at 3rd to 4th week of life. That is a presentation. Why they present at 3rd or 4th week, not at birth? Because initially it is a maternal, inside the body, mother was taking care of all the excess hormones, and they will be washed out, and over a time the precursor 17-hydroxyprogesterone increases, and by 3rd or 4th week when the levels are increasing, that time actually 17-hydroxyprogesterone has got a salt wasting action. That is why the child comes in salt wasting crisis. And we are aware that it causes hyponatremia, hyperkalemia, and metabolic acidosis, pigmentation because of high ACTH, and the next thing is peripheral precocious puberty, which we'll be discussing later. Precocious puberty means hormones are coming, whether male hormones are coming or female hormones are coming. In a girl, if male hormones are coming, it is again a peripheral precocious puberty, but it comes with virilization. In boys, male hormones are supposed to come at 9 to 14 years of age. They are not supposed to come at an earlier age. Here in CAH, if they are having an abnormal defect, they can come with the increased male hormones that present as just a pubic hairs. No evidence of testicular volume enlargement, because only androgens are coming, and they are coming from the adrenal gland. So that is why it causes a peripheral precocious puberty in boys. So cyclical immature and apparent male. So if anyone has a doubt, we can stop in between. Yes, sir. Sir, actually testicular enlargement occurs because of Sertoli cell and Leydig cell hyperplasia. That occurs only with the stimulation by the FSH and LH. That occurs during puberty. If there is some tumor sitting in the brain, if it is causing increase in GnRH level, that stimulates the FSH-LH secretion, that stimulates the testicular volume increase. Per se, androgen testosterone doesn't cause the enlargement of testis. It's a Sertoli cell and Leydig cell hyperplasia which causes the enlargement of testis. That's how we differentiate even the central precocious puberty from peripheral precocious puberty. Where the testicular volume increases in CPP, it doesn't increase in peripheral precocious puberty. But for the clinical features of hyperandrogenism, they have a hirsutism or they have a change in voice, and that is the clinical features of, but we have to find out where is the source. This is the, actually the image is not clear, but it has shown how the child can present at various ages. From the newborn as a salt wasting crisis, abnormal genitalia, till the adult age with just excess acne. Many of the kids go to adults with acne or hirsutism and all that. There, many of them have picked up because of non-classical CH. That is more common than the salt wasting crisis. The incidence is more, almost like 1 in 500, the non-classical CH. But to say virilization in a girl, she can have hirsutism. Many of the girls in our practice, we see many of the girls having hirsutism. Hirsutism and hypertrichosis difference is, hypertrichosis is there is an increase in generalized body hairs. It doesn't restrict only to androgen dependent areas. Androgen dependent areas, we have a thick hairs, but the hirsutism is not like that. Hirsutism is like a regular hair, but it doesn't occur in an androgen dependent area. And in girls, there we get in peripubertal girls who is having PCOS we get a lot of cases with hirsutism and all that. To say virilization in a girl, they should have a clitoromegaly, change in voice. Because acne can occur in girls, the girl develop hirsutism. But if clitoromegaly doesn't occur in a case of normal PCOS, and the change in voice may not occur in normal PCOS. It's usually because of the male hormones, and especially CAH cases and all that, or some androgen secreting tumor, we get that. Otherwise, we don't get a virilization sign in a normal girl. So I'm going off the track also because this is not my PPT, I'm just presenting it. Okay. So clinical features which we discussed, the glucocorticoid deficiency, it comes with a hypoglycemia, lethargy, poor feeding, poor growth and hyponatremia. Mineralocorticoid, polyuria, salt wasting, repeated vomiting and dehydration. As I said, hyponatremia plus hyperkalemia and metabolic acidosis. ACTH excess will come with hyperpigmentation. Androgen excess, as we discussed, separately in female and separately in male. Female comes with a virilization of the genital tract. But in the older age, as we know, for the advancement of the bone, 6 steroids are required. And that should happen between 8 to 13 years in girls and 9 to 14 years in boys. But if it is occurring early in the age, they have an advanced bone age. That is why this is given like that. Advanced bone growth, bone age and early pubic hairs. Sexual precocity in boys, irregular menses. Always the imbalance between male and female hormone causes the irregular menses in the girls. That's what happens in even in CH. And they come to the clinic because of that purpose. This is something called a staging, which we see whether there is just a clitoromegaly, is there a just fusion of the vestibule, there are 2 openings or 1 opening, is it becoming like a male over a time? That is a Prader staging, we use it in that. There is a 1 opening, or is there a urogenital sinus, or the urethral opening is at the tip, completely like a male. There's a various category we see from clitoromegaly till completely like a male appearing genitalia, but no gonads. That is the CH in girls. So what diagnosis we do? So the cases which I showed you, they are presented at birth. Should I evaluate birth? Immediately after birth? Here comes the social emergency, because many people, the moment their baby is delivered, they ask whether it's a male or a female. And it's even legal issues will come in that part. So in that case, we use again a gender neutral term, baby. We don't use a male or a female. We have to use a gender neutral term, baby or a child, newborn. Because we don't know, so we can counsel the parents. The baby's genitalia is looking abnormal, so we need some time to evaluate that, and we'll come with the things. So on day 1, if baby is born, what we can do? We can just do an ultrasonography to see whether child has got uterus or not, whether child has got testis or not, because those are the 2 main things we have to see whether it is there or not. Next, after, you can send for karyotyping, but it will take a month. If an emergency, we can send for fish. What is fish? It usually comes result in 2 to 3 days, fluorescent in situ hybridization technique. We can make out whether XX is there or XY for a fast counseling part. Otherwise, conventional karyotyping is a must to send for all the kids with the CH. Next, after 72 hours, we can send 17-hydroxyprogesterone, because in the first 2-3 days it is not reliable, and so we have to do it after 72 hours. And if it is a CH, it keeps increasing. If it is a normal child, the normal surge would have occurred at birth and it subsides by that time. If it is a CH, 17-hydroxyprogesterone keeps increasing. That is why when we send for the 17-hydroxyprogesterone. And I hope all of you are maybe sending filter paper for the CH screening. The filter paper, if you read, they will give that it is done by IFA technique. IFA is immunofluorescent assay. The lower assays, immunofluorescence assay, radioimmunoassay, they are not very specific. So that level if you get, we have to always confirm by LCMS bar MS. LCMS bar MS is a liquid chromatography mass spectrometry. They do double mass spectrometry so that you get a more precise value. The pathway which I showed you, each pathway differs only by some hydroxyl group or some rearrangement. If you do a radioimmunoassay or you do a IFA, which they give in a filter paper, you may pick up those values. So we may get falsely high values. To be more specific, whether it is 17-hydroxyprogesterone or is just progesterone, we have to have a LCMS bar MS technique. That is the second one. So for screening, we can send IFA, but for confirmatory, if you have any doubt, go for LCMS bar MS. And what happens to electrolytes? Many people call us, shall we send electrolytes on day 3? No, it may not be abnormal at that time. It may get abnormal later as the salt wasting crisis starts. So we can have a one baseline of sodium potassium, and there are a lot of other markers, will not go into that. So the main thing is we want a karyotyping or fish if possible. Do an ultrasonography to see whether uterus is there or not, whether testis is there or not. Then 17 OHP after 72 hours of life. If the child comes in crisis, you are in the emergency and child comes to you at the time of admission in crisis, we always have to take a critical sample. How we take a critical sample for hypoglycemia? Same. Any child which you think the child comes in shock, have a critical sample. At that time you send for electrolytes. That will show you hyponatremia, hyperkalemia, and you do keep another sample for 17 OHP. Because once you give hydrocot, our results get altered. Because only that is a point where we can diagnose. Many of our endocrine disorders, when they come to the casualty, it is the critical sample which determines. Once you give any treatment, we cannot diagnose the conditions. That is the reason. If in doubt, we can send for genetic workup, especially for the prenatal counseling. When the parents want, okay, this is the first sibling which is affected, I want to go for the next sibling. So in that condition, you can send for the genetic sequencing. In that, which is preferred is MLPA. That is because this 21-hydroxylase enzyme deficiency is mainly because of the large deletions. That is why we go for MLPA. If you go for WES, whole exome sequencing, that detects only a single gene mutation, single location. So if you are in doubt, better go for MLPA testing. Or you can ask directly, we want CYP21A2 gene analysis. So go for the case scenarios. This was a 25-day female child. They have done the test here. This is not visible here. 17-hydroxyprogesterone. It was given as 0.55. But please look at the units. Endocrine disorders, please look at the units. Different people mentions different. Microgram per liter or nanogram per ml, nanogram per dl. Whichever cutoffs you know, take that as the reference and do that tests. So here, initial test was normal here. But when they do, NBS on filter paper was actually high. 17 OHP was 424 nanogram per ml. Actually, in the newborn screening, we take 20 as a cutoff. But more than 100 is classical of CH, nanogram per ml. But here, it was a NBS, but it has to be confirmed by a LCMS technique and found that whether it is actually high or it's just because of the other 17-hydroxypregnenolone or 17-progesterone, other things are interfering in that assess. But otherwise, this child was a normal female external genitalia. If they have a normal female external genitalia, unlikely to be it is a salt wasting crisis or a CH. It should be virilized to say it is a CH. So they had actually one more thing. By looking at the child, as I said, day 1, what will you do? If you send on day 1, 17 OHP, it will not be reliable because the normal surge will be there and it will take some time to come down. And preterms will have a higher cutoff. Gestation age, lower the gestation age, lower the birth weight, higher the cutoffs are there. So we have to be sure that the sample is taken after the first 40 to 72 hours. Preterm, repeat the screen, repeat the screening. So whenever you have a doubt, please ask the lab whether they are doing 17 OHP by LCMS bar MS technique. Because nowadays, many of the investigations in SDM and also in KLE are done by CLIA method. That is chemiluminescence method, immunoassay. But here, if you want to more specific for everything, even vitamin D level, if you want more specific, go for LCMS bar MS technique. But it is very costly and not available in many of the things. You can ask the Lalpath or the SR, many of the labs which they do it of. This was a classical child which was, it was like actually a male newborn which was missed at birth because it had a normal genitalia. And the color may be missed many of the times. So it has come at 21 day, 3rd week of life, with lethargy, poor feeding, vomiting and reduced urine output. So differential diagnosis, it's a male child, came in a shock state. So investigations were done. There is a hyponatremia, hyperkalemia, pH was low with metabolic acidosis, creat is normal. So child has not come in acute renal failure, which we expect to be having a hypernatremic dehydration at this age in the summer season. So but child had normal creatinine and sodium was not high, which we expect in this summer season. Urea was little bit on the higher side and sugars were actually normal here, but they usually come with hypoglycemia also. And considering the hyponatremia and all that, maybe they would have picked some color changes between the parents and the child and they would have sent 17 OHP, it had come high. So it is a salt wasting male CH. What we do in the emergency? We always take a critical sample and it is again the pediatric emergency ABC. Airway, breathing and circulation. You can give a bolus till the shock reverse. Here, shock reversal occurs only after you give hydrocortisone. So we can still manage initially with the IV fluids, then go ahead with the hydrocortisone. And what we give is, there's a different age cutoff. If you can remember, 100 mg per meter square at stat, followed by 100 mg per meter square over next 4 hours, next 6th hourly. So newborn, remember 25 mg, little bit older, 50 mg and then older age 100 mg. That you divide later between QID. So this is how we have to manage. And if you have a hyperkalemia, we all do some K binding resins, we give so many things like insulin and all that. That is a management of hyperkalemia. And hypoglycemia, we start the IV fluids. Usually these kids require 1.5 to 2 times the maintenance rather than the regular maintenance dose. And hydrocortisone, if you are in a periphery, if you cannot get an excess, stat 25 mg IM can be given at the emergency. But try to collect the sample as early as possible. The moment you give hydrocortisone, we will miss the bus. So, but here, we are stressing only upon hydrocortisone because when we give hydrocortisone in the stress dose, we don't want a mineralocorticoid dose because more than 50 mg per meter square per dose of glucocorticoid has got a mineralocorticoid action. So we need not supplement mineralocorticoid in this time. So only thing is hydrocortisone at this stage. Once we taper to oral dose, regular dose, we have to start mineralocorticoids. And even they may require salt. So we shift them into 10 to 15 mg per meter square of hydrocortisone TID dose and make sure you give the first dose early in the morning because we know ACTH comes around 4 o'clock in the morning and followed by cortisol comes, and we know evening we don't require a cortisol. So we try to concentrate and we even in fact midnight we don't require a cortisol. Anyone will not have a high cortisol in the night. If you are having a high cortisol in the night, it is a Cushing's. Normally we have a axis only active in the daytime. So try to give the first dose early in the morning around 6 o'clock. Then you can have a TID dosage because it's got a half-life, very half-life. We know the steroid classification. We have a
short acting, intermediate acting and long acting and all that. So hydrocortisone comes in the short acting. So shorter half-life, give more frequently, 6 to 8 hourly. So we give it, sometimes I have given it 6 a.m., 1 p.m. and 6 to 7 p.m. Many of the times I have started with the poor control 4 o'clock in the morning. First dose let it give, so that I want ACTH to come down. If ACTH comes down, no more 17 HP will increase, no more it will channelize to more of male hormones. Our concern is to avoid more of male hormones and manage the normal electrolyte balance. That is why we have to aim at the first dose, be compliant with the first dose to avoid ACTH excess. So we even give a fluorocortisone 0.1 to 0.3 mg. We can give either single or dose, or double dose. It doesn't matter for fluorocortisone, but for hydrocortisone, it's TID or even QID if possible. Then salt, in spite of giving fluoricort 0.3 mg, have you seen the fluoricort tablets? It comes as 0.1 mg. We are given 3 tablets, sodium is still low, 120, 125 and all that. Because kidneys are so resistant in the first 2 to 3 months, we added even salt to that. After adding salt, the sodium picked up. So kidneys are very resistant in the first 2 to 3 months of life. We may require salt if there is no response to 0.3 mg of fluoricort. So education is the most important thing, because the next question is it like a course for 3 months or 6 months or 1 year? It's a lifelong condition, because here we have to avoid male hormones and let the child be reared as a female. So once you start treatment, always and again we look for the electrolytes, we look for the 17 OHP, we look for the total testosterone. Our aim is to normalize the male hormones. Normalize means they shouldn't be there in the females till they attain puberty. In puberty, every girl will have a testosterone hormone, but it shouldn't be there in the younger age. At the end of the day, again, endocrinology is also growth and development. So we have to have a normal growth chart and see how the child is having a normal trend in the growth. That's why we have to monitor these things. So what I do in my clinical practice is, we have a growth chart properly and how the child is growing. We monitor sodium, potassium, total testosterone. 17 OHP is bit costly, we don't go for that again. Total testosterone, we ask here. Many of the patients from SDM, they come with the report to the KLE. So we aim total testosterone less than 10 nanogram per DL. If it is less than 10 nanogram per DL on follow-up, it means it is adequately suppressed and you can continue. And sometimes if we miss the morning dose, the bone age can advance. Yearly bone age has to be seen, because these kids, limited amount of testosterone if is coming, their bone age will advance, they enter the puberty, they enter to be short. That is why we don't want them to have a more male hormones or whatever it is. So, and the next thing comes is, we have lost 2 kids in the last 1 year. They were a CH cases, and during fever they missed to give the stress dose. It was told to them the child requires a stress dose. Whenever we have a fever or some vomiting or loose stools is there, but not for simple cough and cold, during fever or loose stools, they have to double or triple. Our body mounts the cortisol response double or triple. Their body doesn't mount that response, so we have to have a double or triple. If they are giving high zone 5 mg, half, tell them 1, 1, 1 or 1.5, 1.5, 1.5 till the fever is there. If in spite of that doubling or tripling, child comes in shock, we always give them the vial of hydrocortisone and 2 ml syringe, and we tell them that if this child is found in shock, please give 50 mg or 25 mg IM hydrocortisone and refer to the concerned hospital. Because those 2 kids, they missed the bus and they landed up in, they died. Because they, in spite of telling, they have not given the stress dose. If this child is found in shock, definitely we give IV. If IV is not there, please give IM. And anyway, hydrocortisone injection is not so costly. They can preserve it till the expiry date. Once they can keep purchasing it off, because it's an emergency drug and that can save the life of the child. So apart from giving oral high zone and fluoricort, give them the hydrocortisone vial. That can maintain their life. So double dose up to 102 degrees Celsius, triple dose more than that. If child is in shock or not able to take orally, please go ahead with the IV injections. Okay, this is similar. Actually, this looks like a male, but if you palpate, there is no gonad. It looks like there's a gonad. Always in those conditions, please palpate for the gonad. what we can do is we can try palpating from the deep inguinal ring. Just try to feel. You can feel that testis is there or not. If you're not able to palpate till the base of the labioscrotal fold, then we can definitely say the child doesn't have any gonads, and it can be always confirmed by an ultrasonography. And you have to mention in the scan that whether there is a gonad or not, please tell us, and look for the Mullerian structures. That's a must, because many of the reports when we ask for USG abdomen, they don't even mention about the uterus. It has to be particularly asked whether child has got gonads or uterus. Okay, this is a later age of presentation, I think actually. We'll skip this, sir. One point about the peripheral precocious puberty asked about that case, sir. Here, the child was a 4-year, 10-month male. He came with pubic hairs and penile enlargement. For penile enlargement, only testosterone is required, but when you look at the testicular volume, it was 2 ml. Because, so the genital examination is important part. If testis is also increased, the thing has started from the center. If testis is 2 ml, but child has signs of secondary sexual characteristic, it is somewhere the male hormones are coming, but not from the center. It is either the male hormones are produced or the female hormones produce mainly testis, adrenals and the ovary. So when you ask for the scan, look at the whether any mass is there in the adrenal or is any hyperplasia is there or ovarian cyst is there for the females. So we particularly have to speak with the sonologist. We are looking for these things, please see. So this was a case of peripheral precocious puberty, and you can make out that at that child of 4-year, 10 months, he was actually weight was higher side, but our concern is mainly the height. Height is here, mid-parental height is here. So child is definitely taller, but don't expect child is going to become taller like this, because this advancement is, this height spurt is because of the male hormone. When you look at the bone age, we always mark the bone age like a cross. Dot is for the height. When you look at the bone age, it is so advanced. The child may fuse and end up to be short. So here, plotting a growth chart will solve many of the cases. Or simple growth chart can solve, and simple genital examination will diagnose many of the condition. Ultrasonography investigations are for supportive role. This is, I think we'll skip this. Okay. We want this or we can skip, sir? That what I have got, I can show that, sir. Okay, fine. It's okay if I continue the same others, or if on the case presentation by the students, sir. Yes, sir. Other lecture will be boring actually. Yes, sir. Airway breathings, yes, sir. Yes. Shock. Oxygen, sir. Yes, sir. Thank you. Yes, sir. True, sir.
Thank you, ma'am, for your valuable insight. It has added great depth to our today's CME. Now I call upon Dr. Bhagyashree, Junior Resident, SDM, for her case presentation.
Actually, this session was supposed to be taken by Dr. Ganesh and myself. Dr. Abhishek will join soon for the sessions.
Good morning, everyone. I'm Dr. Bhagyashree. I'm a postgraduate in STM Dharwad. Moderator is Dr. Shaila ma'am. I'll be presenting a case of XYZ. She is 4-year, 4-month-old girl hailing from Dharwad. Date of examination is 15th of February 2025. Informant is mother and she is reliable. Chief complaint: failure to gain height adequately for past 6 months and constipation since past 6 months. History of present illness: child was apparently normal until 6 months ago. Later, mother noticed her child was not gaining adequate height since 6 months. She is short when compared to girls of her same age and child is sitting in first row of her class. She is not outgrowing her clothes and shoes since 6 months. Mother also noticed child to have constipation and child passes stools once in 3 to 4 days in past 6 months, which is hard in consistency, requiring staining while passing stools, not blood tinged, not associated with abdominal pain.
Okay, your chief complaint is failure to gain height. Okay, so what do you want to think at this stage?
Delay in height.
You can go to the next slide.
Negative histories. No history of poor appetite or inadequate dietary intake or pedal edema. No history of abdominal pain, chronic diarrhea or oily stools. No history of polyuria, oliguria or polydipsia. No history of recurrent fever, cough, cold or wheezing. No history of easy fatigability, shortness of breath. No history of bony deformity or recurrent fractures. No history of headache, vomiting and visual disturbances. No history of delayed dentition.
Go back to the first slide. Okay, your chief complaint is a concern is the height in the children, and the second concern is constipation. Okay, fine. The next slide. Okay, how to define short stature when usually the parents present to the clinic?
Either through growth charts, ma'am.
Growth chart, they never come with a growth chart.
A mother will be concerned that when compared to the siblings or a child of a same age like classmate, the child is not growing adequately, or when they stand for assembly or something, child will be standing in the first row, has to stand in the first row, or she is not outgrowing her dress or shoes or chappals.
Since many 1 or 2 years or 3 years, they are taking the same size clothes for the child. Okay. Next. Constipation, is it functional constipation or you think of something else here? Because it's the age when they have a constipation, right?
Yes,
Between
yes,
some 2 or 4 years.
Yes, ma'am. Since it is associated with the short stature, so I would think of, I would take it like
some symptom. Yes. Okay, but otherwise it can be a functional. Don't take every constipation is a hypothyroidism.
Yes.
Some toilet training is also a part of, should be thought of that.
Yes.
So why you asked each negative history? Please clarify that.
Yes. No history of poor appetite or inadequate dietary intake or pedal edema to rule out protein energy malnutrition, ma'am. And no history of abdominal pain, chronic diarrhea or oily stools to rule out malabsorption and cystic fibrosis. And no history of polyuria, oliguria or polydipsia for chronic kidney disease as well as renal tubular acidosis, ma'am. And no history of recurrent fever, cough, cold or wheeze for chronic respiratory tract infection and asthma.
Per se asthma, you get many of the cases of SAM in the ward which are of cardiac conditions. So many of the short stature, what we get, the failure to thrive, recurrent chest infection should be the first thing. So that is a presentation. Because before we go for the endocrine causes, rule out the systemic causes. Your cardiac, what you said, the loose stools for the malabsorption syndrome, kidney diseases, because sir said creatinine is an important part of investigations and all. Okay.
No history of easy fatigability or shortness of breath for congenital heart conditions, ma'am. No history of bony deformity or recurrent fractures for skeletal dysplasia.
They don't come with the recurrent fractures. They usually come with the abnormal body stature or some disproportionate short stature is their complaint. They come with a bony deformity, but not with the fractures. With fractures and polyuria, you said earlier.
Like renal tubular no history of headache, vomiting, and visual disturbances to rule out intracranial space occupying lesions, mainly craniopharyngioma or pituitary adenomas.
Yes.
No history of delayed dentition as a part of nutritional rickets.
That's another aspect. So, have you examined the mouth of a 2-year or 3-year-old child? When you have seen all the 20 teeth in a child, that's another aspect. Temporary tooth are 20, right? When they appear?
By 6 years of age.
6 years. Temporary tooth. 6 to 7 months.
6 months.
Okay, when you say it's a delayed dentition, and which condition you're thinking in this case?
If there is no single tooth appearing by 13 months of age, then I would tell it as a delayed dentition, ma'am.
In this case, what you want to see? Why you asked in this case?
Nutrition, rickets.
Nutrition is one aspect. Anything else? One examination of a dental examination. Usually by 2 to 2.5 years, they have their all 20 teeth.
Yes.
So another the things comes only at 6 to 7 years, the first molar. So between 2.5 to 5 years, no more teeth comes if it is normal child. Okay. So at the end of HOPI, what are your chief complaints?
Failure to gain adequate height and constipation.
Which you are not sure what is the condition.
Yes.
Okay, fine.
Past history. No history of recurrent hospital admissions. No history of long-term steroid intake. No history of chemotherapy, radiation or surgery. No history of TB, asthma or other chronic systemic diseases.
Yeah, please explain each and everything.
No history of recurrent hospital admissions. Any recurrent systemic illnesses like asthma or chronic heart disease where child comes with recurrent chest infection, or asthma where child comes with recurrent wheezing.
Asthma, does it come with the concern of short stature if you are giving a spray, steroid spray?
If it is very high doses for a long period of time.
But that much of dose causes a growth suppression. And many of the times we give a short course of steroids like 5 days. 5 days doesn't cause any growth suppression unless you're giving it more than 2 weeks or months together. So per se the spray may not cause.
Nephrotic syndrome with the chronic
That is the oral steroid you are giving for a longer duration. Recurrent asthma per se it may not, but recurrent hospital admission may hamper the nutrition part. That can cause the growth failure. Rather than the asthma per se causing, recurrent hospital admission even in cardiac conditions or any conditions, child have that nutrition deficits that can have some effect on the growth. Okay. Lungs.
An important point is chronic untreated asthma causes growth failure. Inhaled steroids do not. So growth suppressive doses of inhaled steroids are budocortisone more than 400 microgram per day over a prolonged period. That is usually not required. Usually up to 400 micrograms a day as a preventer, and then it is tapered down by pediatricians or pulmonologists. So it's a very important point that Sheila made is rather than fearing the inhaled steroids, it's the untreated asthma that is associated with growth failure.
Second point.
Long-term steroid intake.
So the conditions are?
Nephrotic syndrome.
Yes. In that condition, apart from height, what complaint will be there in the child?
Weight gain.
Yes, that should come as a second point. Failure to gain weight and height, or failure to gain only height. Okay, apart from the weight gain. That should be mentioned clearly.
Yes.
Okay.
No history of chemotherapy or irradiation or surgery.
Yeah.
Chemotherapy with many
of the cases here, ALL cases, AML cases, they would have taken the radiation. They do give chemotherapy and radiotherapy. So what it can cause? If they have involved the cranial area it can damage the pituitary, that can cause radiation induced pituitary hormone deficiency, or it can damage even the thyroid gland. So it depends upon the duration of exposure and also the amount of radiation which has been given, that can cause. So in that history, you will have a past history of child being a case of
Any neoplastic?
some neoplasm, taken chemotherapy or radiation. They get referred to you from the hemat-oncologist that the child is a case of ALL on treatment for the last 3 years. Child is in remission now. Concern is the height. That will be the concern. It cannot be just like in this case. Okay.
No history of TB or asthma or other chronic systemic disease.
She's behind asthma. Okay. So they look for mainly the cardiac, respiratory, or renal tubular acidosis, or the CKD, or the GIT malabsorption, and cranial any features are there. That we have to look in the HOPI.
Family history. She's a single child to a non-consanguineously married couple. There is no history of short stature in family. Mother and father attend puberty at normal age. No history of significant illness in family. No history of disharmony in the family.
Yeah, every sentence you have to explain.
Uh,
First sentence you can leave, second you can go.
No history of short stature in family, ma'am, to rule out familial short stature.
Okay, but there's something like one father is very tall, the mother is 145 and 148. Is it a familial short stature or something else you have to think of?
Autosomal.
Not everyone who is short in the family is a familial short stature. She can be an untreated hypothyroidism which has become short. She can be a growth hormone deficiency. So not everyone short in the family, don't take it is just a FSS, familial short stature.
So what Shaila's wanting to clarify or rather emphasize is it could be polygenic familial shortness, which is a trait, or it could be an inherited pathologic cause of short stature running in the pedigree. So you must, that's why when you see a gross discord in the heights of the couple, always rule out a pathology in the shorter individual.
And in our community, they do a consanguineous marriage, and if the short girl is there, we can get married to our own relative. So that is the thing, and we end up thinking it is FSS. We get many of the cases like that.
Mother and attainment of puberty, ma'am.
How to ask that?
With mother, we can ask menarche when she has attained, and father shaving when he has shaved.
Yeah, because the clinical evidence of testicular enlargement will not be known to us. So in mother, we ask for menarche, but father, we ask for the shaving and when the height spurt was noted and all that. Okay, fine. Why?
For CDGP, ma'am.
Full form.
Constitutional delay in growth and puberty, ma'am.
Okay, fine. Next.
No history of significant illness in the family.
That's okay. Next.
No history of disharmony in the family, ma'am. Disharmony per
In the
se.
sense?
Why did you ask specifically for this? It's a rare entity, but is a well-documented entity.
If mother and father, they have any divorce or any serious condition going on in the family, it will affect the development of the baby, like emotional development and the tender loving care they'll not be able to provide.
Yeah, so an entity called psychosocial short stature, wherein there is functional resistance to the action of the growth hormone at the level of the receptor, or impaired signaling of the post-receptor transduction pathways. And the issue is more psychologic rather than organic. So it's a documented entity in world literature, is very, very rare, was unseen in our social setting till recently, but the high incidence of marital discord now and disharmonious family environments, we will surely make a diagnosis of psychosocial short stature once in a while.
Antenatal history, ma'am. First
Only
trimester.
say the positive points. You can go ahead. Anything in the what you want to ask in the antenatal history, which can be a cause for short stature?
One is age at conception of mother.
That doesn't matter for the short stature.
Ultrasound scan, ma'am. limb length for
Yes, that's a
limb length.
good thing.
Then maternal nutrition and maternal weight gain, ma'am.
So what it affects?
It will cause the fetal growth restriction, ma'am.
So?
IUGR. The fetus might be having a primordial dwarfism.
Primordial dwarfism are different conditions. There are some genetic conditions. Primordial alla. Baby is born
SGA
small
babies,
for
ma'am.
gestation age. That's the thing. But if the baby is SGA, the cause is in the first trimester or in the third trimester. What are the causes for causing SGA in the first trimester? Which can cause a small for gestation age?
Uterine anomalies, ma'am.
Uterine anomaly per se causes defect in the last trimester. First
Maternal
trimester causes for short SGA, which you actually label as symmetrical IUGR.
placental insufficiency.
Placental insufficient, all are. Any syndromes or infections can cause.
Torch infection in mother or teratogenic drug intake.
Yes.
Irradiation in the mother.
Yes. One syndrome, famous syndrome.
Sickle syndrome.
D.
Down syndrome.
Yes.
Down.
The importance is why they all are born with the. They have SGA. We use a IUGR intrauterine, but at snapshot at birth is SGA. But what causes SGA in the last trimester? Why last trimester is required? Is it for organogenesis or anything else?
Maturation of the development.
It's just a increase in the size and the number of cells. So that can also cause. Which conditions you mentioned that PIH, anemia and all that can cause. Okay, fine. So to summarize antenatal history, I think we have to just look at the number of siblings, what they are having. Any child is short or whatever. Birth weight is an important part because we want to know whether child is short at birth. And we all have, there is something called a short for weight, small for weight, small for length, small for weight and length, and also for head circumference. As she mentioned, we recently got a case who was got for short stature. When we looked at the child was having disproportionate short stature. I asked the mother because I found the limb length was small, and I asked for the antenatal scan. In the antenatal scan, when we look at the weeks, femoral length was less. Everything was something like 33, 33, 33, and the femoral length something like 29 weeks. When I asked the mother, she told even the father looks like that. Even he is. So it is not a growth hormone deficiency. Everything we get is not a systemic cause of growth hormone deficiency. Subtle changes in the limb length can come as that. So many of the cases, if you have a doubt, please get the antenatal scans. You will come to know what is the gestation age. They mentioned definitely what gestation age, what it was mentioned in that. That is one aspect which you brought. We have to see for the length of the things. Discordance.
I think that's probably one of the most important parameters for genetic, like pathologic gene variant driven short statures like achondroplasia, hypochondroplasia. The simple word is short long bones. I mean, if you see short long bones on a fetal ultrasound, you know it's coming. It's a skeletal dysplasia or a disproportion.
So in that condition, so everything is not GHD. So every short stature is not. So subtle change, that's why the importance of measuring upper segment, lower segment ratio. I think we can skip that. Birth weight is the one thing which we are.
2.3 kg, ma'am.
So not so short like SG also, borderline. Okay.
For the cephalic presentation, ma'am.
You asked about natal history. You had asked something about no history of.
No history of birth asphyxia, seizures or prolonged neonatal jaundice, neonatal hypoglycemia or swelling of limbs at birth.
Yeah, explain something about that in the.
One is history of seizures or prolonged neonatal jaundice and neonatal hypoglycemia for hypopituitarism. And swelling of limbs at birth, mainly in the female child for Turner syndrome.
But not usually. Birth asphyxia and cephalic presentation, any relevant in that?
Hypopituitarism child also might present with the breech presentation. So presentation of the child.
I don't know the reason. Breech presentation comes with the dissection of the pituitary, or the MPHD comes with the breech presentation. It's very difficult. But whenever they have a breech presentation and the birth asphyxia, please look for the MPHD. MPHD is multiple pituitary hormone deficiency. There can be pituitary stalk interruptions.
No feeding difficulties, ma'am. In the case of Prader-Willi syndrome, because of hypo.
No, first Prader-Willi, it's the nutrition part. Whether baby is been fed normally till exclusive breastfeed till 6 months, don't go for the syndromic causes. First, always the dietary intake part. Endocrine causes are less than 5%. Please look into the diet pattern and the systemic illnesses first.
Postnatal history, a child was exclusively breastfed for 6 months, followed by appropriate complementary feeding. There was no history of feeding difficulty.
Feeding difficulty you said for something?
Prader-Willi is
hypotonic babies, they may be having a difficult. One of the DD is Prader-Willi. Okay.
Which is the commonest syndromic hypotonia that causes feeding difficulty in the neonatal period?
Downs.
Yes. So Downs, then Prader-Willi, and then Russell Silver.
Immunization history, ma'am. Child is immunized as per schedule. Dietary history, mixed diet, no food aversions or dietary restrictions in the family. Expected calorie was 1350 kilocalories, observed was 915. So there is deficit of 435 kilocalories, and proteins expected was 15 and observed was 10, and deficit of 5 gram per day.
It is always a matter how did you calculate the calorie, katori says kitna it depends on that. Okay, fine. So if it is normal, you can skip. Or if it is abnormal,
no.
Why can be abnormal in some conditions? Please explain that.
Short stature with developmental delay. One in case of syndromic causes like Down syndrome or Turner syndrome
Turner syndrome coming with usual developmental delay is not so common. It's a Noonan's come with developmental delay, not the Turner syndrome. Anything else?
Congenital hypothyroidism.
Yes, but the presentation is more of a developmental delay rather than the height issues. Okay. Fine. Go ahead.
This child is developmentally normal. Socioeconomic history. She is born in a nuclear family.
I think you can skip this. It's okay, fine.
Summary. She is 4 year 4 month old, developmentally normal child with insignificant perinatal history, with complete immunization status, with no significant past and family history, with dietary deficiency of calorie and protein. She came with the complaints of inadequate gain in height in 6 months and constipation in 6 months.
So the differential diagnosis is
at this point, I'd be taking constitutional delay in height, acquired hypothyroidism, and nutritional cause of short stature.
Okay, go ahead with the examination.
Anthropometric. Child's weight observed is 12.3 kg, expected was 16.8 kg. Inference is between -3 standard deviation to -2 standard deviation. Height is 89 centimeter, expected was 105 centimeter. Inference is less than -3 standard deviation. Weight for height is 12.3 kg, expected is 12.6 kg. Inference is median to -1 standard deviation. Head circumference 49.5 centimeter, expected is 49.6 and between +1 standard deviation to median. Mid-arm circumference is 16 centimeter. Height, age.
Have the growth chart? Okay, interpret here, better it is. Yeah.
Child is 4 year 4 month old and her weight is 12.3 kg. It is between 3rd centile to 10th centile. And her height is 89 centimeter and it falls below less than 3rd centile. So she is a short stature. Then weight age comes around 2 year 4 months and height age comes around 2 year 2 months.
So, though not the gospel, generally postgraduates are taught that if the height age is affected more than the weight age, think of endocrine. If the weight age is affected more than the height age, think of chronic systemic illnesses. I mean, the rule doesn't hold good when you're dealing with syndromic and dysmorphic children.
Then the target height. Target height, child is falling, I have plotted the target height and if we trace it, it falls below the target height at adolescent.
So what enter from the growth chart, which is the more affected here?
Height is more affected than weight in this child.
So as sir says, nutrition causes even the weight should be affected, which is not in this case. It's the height is affected, weight is preserved. Okay.
So this is the head circumference, it's normal. And weight for length is also normal. The child with the measurement of height. General physical examination. Child was conscious and alert, had a dull look. Child is oriented to time, place and person. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema noted.
Any positive findings?
It had dull look.
That's it. Blood pressure is normal?
Yes, ma'am.
Okay.
Vitals wise, normal.
Okay, next.
Head to toe examination.
Any significant you can say?
Heart rate, ma'am. In case of hypothyroidism, untreated severe, there might be bradycardia.
Okay, fine. Okay.
Then Cushing's disorder, there might be hypertension. Intracranial space occupying lesion might increase the ICP and may cause bradycardia and hypertension and respiratory abnormality.
But the presentation is different. They can't come walking to the hospital. Okay. Anything positive we have to see in the head-to-toe examination, you will summarize and why you look for that.
In this child, there was increase.
No, any case from head-to-toe examination, what you look for and what is that infers?
Syndromic case.
General cases like palate, what you look for and what you think of.
Mid-facial hypoplasia, or in the case of growth hormone deficiency or hypopituitarism, they'll have doll-like face. And then in Down syndrome, Cushing syndrome,
like you have got a cleft palate, think of midline defects. You got a goiter. How is the skin?
Coarse, dry skin.
Yeah, that you should see. What clinical feature and what is the meaning of, like what it says. Highlights. If child has got jaundice, if child has got umbilical hernia, what it indicates.
Congenital hypothyroidism.
That positive point you should say. Any limb length deformity, limb length discrepancy you have seen?
Yes, ma'am. In this child it is not.
It is not there. So what you see, we look for the limb length discrepancy and facial asymmetry will be there and all that. Okay. Russell-Silver syndrome. Okay, go ahead.
Her face was dull looking. There was no mid-face. There was mild facial puffiness, but no coarse facial faces and no midline defect, ma'am. No cleft lip, cleft palate or crowding of teeth. No goiter or other neck swellings. There was no webbing of neck, pigeon chest or Harrison sulcus. So
describe them.
There is generalized increase in the body hairs, involving trunk, limbs and face. It is not restricted to the just chins or this one.
Hypertrichosis, you can use the word.
Hypertrichosis.
These kids, they look pale because of that edematous appearance, no? They do look pale. There's some sallow appearance, dull looking, that you can describe. Okay.
No, there were no skeletal anomalies.
Examination, investigation. So what do you think at the end of the examination along with the HOPI? Summarize. Next.
4-month-old developmentally normal child with the insignificant perinatal history with complete immunization status, with the no significant past and family history, with the dietary deficiency of calories and protein. She came with complaints of inadequate gain in heights in 6 months and constipations in 6 months. On anthropometric evaluation, child heights is below -3 standard deviation. Weight for age and height for age is delayed. Bone age corresponds to
that should be done later. Okay.
Child's height falls below the target mid-parental height, and on examination, child's vitals were stable. On head-to-toe examination, child had excessive body hair, hypertrichosis, and mild facial puffiness and dull look. Child had dry and coarse skin. Systemic examinations were within normal limits.
So the diagnosis is?
Acquired hypothyroidism.
Why acquired hypothyroidism? Why not congenital hypothyroidism?
The presentation, age of presentation.
Anytime. Congenital can present even later age. What else they will have in a congenital hypothyroidism which differentiates from acquired?
Developmental normal child, ma'am.
Developmentally normal child can one point which can differentiate congenital from acquired. Go ahead with the investigation. Still want to think of CTGP and nutritional costs?
No.
Go ahead. Because weight is preserved. Your calculation may be wrong in the diet part. Next.
Laboratory evaluation of the child. Her HB was 9. Total leukocyte count and differential leukocyte counts were normal.
Okay.
Platelet
Why you
count
want to say HB when you say 9? What do you want to look at that? Any other parameter you look in the HB?
Iron profile.
Okay. Will you want to look at MCV?
RBC index. Um,
So the anemia, if it is associated purely with the hypothyroidism, primary hypothyroidism, would be normocytic normochromic. But generally in our settings, there can be coexistent microcytic iron deficiency which masks the picture. So you might have altered RBC indices. But generally isolated hypothyroidism related anemia is normocytic normochromic.
in this child, on iron profile, the iron was low and total iron binding capacity was more, which was inferring iron deficiency anemia. And the vitamin B12 and folate was the normal. RFT, RFT was normal, electrolytes were normal, ABG was normal, CRP was normal. Thyroid profile, free T3 was 0.391 picogram per ml, free T4 was 0.083 nanogram per deciliter, TSH was more than 100. Anti-TPO antibodies were positive, it was 173 international units per ml. USG of the neck, no significant abnormality was seen. However, thyroid uptake scan, technetium scan showed near normal or mildly reduced trapping function by thyroid gland, which was consistent with hypothyroidism.
So in this case, a positive TPO antibody, thyroid peroxidase antibody, tells you the cause is autoimmune. The other antibody that you would look at if the thyroid peroxidase was negative would be the anti-thyroglobulin antibody, the next affected. And also chances of nodule formation in the gland affected with thyroiditis is higher when the anti-thyroglobulin antibody is positive. So in this case, we wouldn't have probably done the technetium scan because the diagnosis is unequivocally primary autoimmune hypothyroidism. We would probably add the Doppler mode to the ultrasound to see if the vascularity is altered as it is in cases of thyroiditis. So your diagnosis here is severe primary hypothyroidism because your free T4 is almost undetectable and autoimmune in etiology. And you can add whether it is goitrous, non-goitrous. In your case, it is non-goitrous, right?
Cortisol was normal and UST of abdomen and pelvis was done since she had hypertrichosis and things. It was normal. X-ray of left wrist and hand showed bone age corresponding to chronological.
This is something I would beg to differ because severe hypothyroidism is the commonest cause and the severest cause to retard the bone age. And here, because the TSH is more than 100, I assume the disease has been long standing. So it would have affected the bone age, and I think you should have a relook and estimate the bone age again.
Okay.
So in the now very good question. I was going to come to it. In your anthropometry, you had not taken the segments, or maybe I missed it because I joined in late. So retention of infantile proportions is often one of the hints towards severe hypothyroidism. So you would see retention of the infantile proportions. Additionally, towards the later part, when we are dealing with boys with constitutional delay of growth and puberty, the upper segment, lower segment will depict a shorter trunk and a relatively longer limb length. And obviously skeletal dysplasias make it very explicit because one of the classifications clinically that we use is this shortness, short trunk, short stature, or short limb, short stature. But then generally with the trained eyes, the features are so explicit that it is only a formality to document. And another important thing that we do is the arm and forearm ratio in chondrodysplasias, or when you want to classify it as rhizo, meso, or acromilic, short stature. The take-home message here is you will start treating with thyroxine. Because it is a severe case, you will probably treat for the first 2 weeks with a slightly lower dose than the usual threshold dose. So the principles are different. If it's congenital and you're treating in infancy, you will use the highest ceiling dose threshold to quickly optimize the free T4. Here this child is 4.5, has had long-standing autoimmune, which is an acquired hypothyroidism. So the dose replacement has to be phasic. And and you have to keep this child under surveillance for evolution into other autoimmune endocrinopathies. So currently for hypothyroidism or hyperthyroidism, in endocrinology, management is limited to hormone replacement or using anti-thyroid drugs in the other case scenario, and we do not offer therapies like rheumatologists do or disease modifying anti-rheumatologic drugs. No, those are not offered.
Thank you, Bhagya, for well-organized and structural presentation. Now I call upon Dr. Malangauda H. Patil, Junior Resident, for the next case presentation.
Good afternoon, everyone. I'm presenting a case. It's a 9-year, 7-month-old boy, Manikya, from Hirekopa of Saudati Taluk. A child was brought with complaint of swelling in the left chest since last 6 months. On HOPI, 9-year, 7-month-old child brought with history of swelling in the left breast since last 6 months. Initially noticed by the mother, having a size of marble, slowly progressed to have a size of lemon, which is not associated with the pain, not associated with any discharge from the nipple, not associated with any skin discoloration. Otherwise, there is no history of fever, no history of trauma to the chest, child was not on any medication, and no history of any early menarche in siblings. Otherwise, his child is pastly, there was no past significant history, and birth history, family history wise is a second born child to non-consanguine married couple. Birth history is not significant, as a child born by LSCS with birth weight of 3 kg, no history of NICU stay. Child was not on any medications, and diet history and developmental history, immunization history is appropriate for the age. On examination, and vitals stable, and on anthropometry, height for age is 129 centimeters.
At the history level, what is the diagnosis?
It's a unilateral thelarche, ma'am.
Thelarche we use in boys or?
Girls, it's most unilateral gynecomastia.
Okay, it's a left-sided gynecomastia, but there is no significant history of any.
Not on any fever, ma'am. Which is
fever or anything else you want?
Now tell me, if you see gynecomastia in a boy,
yes,
I mean obviously gynecomastia will occur in a boy. What are the other signs that you, or rather in history, what are the other features that you will ask the parent for?
Any other sexual maturity findings, such as axillary hair, pubic hair, penile enlargement.
Yes, very good. Will you also ask for history of probable contamination or probable consumption of certain medications or accidental exposure to certain phytoestrogens?
Yes, such as steroids, anabolic steroids, which will cause though bilateral gynecomastia, and other androgens containing drugs, CNS drugs such as the diazepam tricyclic antidepressant, or any heart medication such as calcium channel blocker or digoxin.
You asked about the family history. Is there a family history of gynecomastia?
No, ma'am. There is no family history of gynecomastia.
It is not there.
Yes.
Okay. The child is developmentally normal child?
Yes, ma'am. Developmentally.
Any particular thing, social inhibition, like child doesn't have a mingling and all that?
No, ma'am. Appropriate
Not
for
there.
the age. Yes.
Okay. Any particular thing you want to think in that condition? Child is.
One is most common is a trauma, ma'am. There is no history of trauma, and otherwise mastitis, no history of any fever or.
Mastitis to have, there should be a gland also. It's not there actually. It's just a development is there, and okay. Any discharge you asked?
Yes, ma'am. No
discharge or galactorrhea. Okay. Anthropometry.
On anthropometry, weight for age is 10 to 25th centile. Manikya. Next. Weight is 24.5 kg and it is 10 to 25th centile, and height is 129 centimeter. It is 10 to 25th centile, and BMI is 14.7. It is at 25th centile, and height age is 9 years 6 months, and bone age is 9 years.
So interpretation. And why you're looking at anthropometry in this condition?
So
importance of anthropometry.
one is malnourishment, malnutrition, which is associated with abnormal enlargement of the either parotid glands, gynecomastia, malnutrition, even short stature, which are associated with, and HPA axis depression, which is also lead to.
It's the obesity which you are looking.
Early onset of
Puberty.
puberty. So the accelerated height centiles is what you want to look at.
And I think we should reserve the bone age for later when we start evaluating. So currently we'll go clinical. Your anthropometry is not suggestive of accelerated growth, or maybe this is a cross-sectional one-time height plot, so we do not know.
So and concerned more of obesity here.
Yeah, yes, ma'am, and
Yeah.
obesity and even increased height.
Yeah. Compared to the target, should
Target
always
height.
have a target height.
Yes.
Anything.
And on SMR staging, external genitalia is prepubertal. Testicular volume is it's documented, ma'am, less than 4 ml.
Mention
Axillary
specifically 2 ml you can mention.
Yes.
Okay.
Axillary hair is absent, even pubic hair is absent. Interpretation is stage 1, it is prepubertal.
So what do you say at the end of the SMR staging? I hope systems are normal.
Yes, ma'am.
Okay. So what you diagnose at the end of the HOPI and examination?
So though it's a prepubertal, still age of the child is 9 years 6 months. There is a still potential to gain sexual maturity. It's normal.
So it's a prepubertal unilateral gynecomastia.
Gynecomastia.
Okay. So what are the DDs you think of at this stage? You know gynecomastia is what? Just for a brief history taking. What is gynecomastia?
It's abnormal enlargement of the breast tissue.
So what are the normal ages when it occurs commonly in the boys?
Female.
Boys. Normally when you see gynecomastia, there is a physiological gynecomastia at various ages. When you see that?
One is neonatal age, ma'am.
Yeah.
That will during the initial 28 days.
It can't be 28 days, it will be there. So why the neonatal gynecomastia occurs?
One is maternal androgens, which is causing the
It's the estrogen which is causing the gynecomastia or the androgen which is causing?
estrogen.
Yes. Neonatal gynecomastia is because of maternal estrogen transfer.
Estrogen.
Next. Second physiological gynecomastia at what age? Pubertal gynecomastia. Usually during the mid-puberty it is very classically seen, but otherwise at the third gynecomastia, physiologically it can be seen with the geriatric age. So the across neonatal, pubertal and the during the this one, geriatric age we can see the gynecomastia, and it is usually physiological. In this case, as you said, it is a pre-pubertal gynecomastia. So do you think it is abnormal or normal? Because always we see the growth chart and the testicular volume gives many clues to us.
Yes.
So I know it is a pre-pubertal gynecomastia. So what do you want to think?
One is abnormal, ma'am.
Yes.
It's unilateral.
Yes.
It's like less likely of having central causes, most likely of peripheral cause.
What do you want to look at these things? You would have done a local examination.
Yes, ma'am.
Is there any evidence of trauma to the child?
No.
You think it's because of trauma?
No.
Is there any redness?
No
Or any
redness.
discharge?
No discharge.
Is there any galactorrhea?
No, ma'am.
It's not there. So
When you palpated the testis, did you find any asymmetry in the testis? Or did you have a palpable liver?
No palpable liver, sir.
Okay.
But There is undescended testis. The right testis, it's at the level of inguinal region.
So prepubertal gynecomastia should worry you. As Shaila rightly pointed, gynecomastia is an entity that that occurs in 20% of the boys during puberty, usually mid-puberty or beyond. It's also important to assess what stage of puberty has the gynecomastia developed. So if someone comes with a testicular volume of 4 ml and depicts a TANUS 3 of gynecomastia, we don't assume or presume it to be pubertal gynecomastia. In your case, the TANUS stage is 1 and you have an asymmetric gynecomastia, left-sided, so you should be worried to rule out pathologic causes of gynecomastia before we conclude that it could be because of accelerated aromatization. That is what Shaila was asking you, what about other family members? So usually in genetic accelerated aromatization, multiple family members would have had it. Or then we are worried about certain secretory lesions that could typically HCG secreting, which could cause a prepubertal gynecomastia, or then a part of certain genetic syndromes, or then physiologic, or rather not physiologic but idiopathic, for which we do not have reasons. Yeah.
So as I said, drugs is one of the thing which will be missed many of the times. Would have given some ranitidine, Pantop and all that, which will have a inhibitory and that can cause a high prolactin. That is one thing which can cause a breast enlargement, and they can come with galactorrhea, need not be every time. So that is one thing. Drug history is an important part. Many of the child may be, he said, sir, on seizure medications and drugs. Okay.
Not on any
Medications.
medication.
Okay. So what investigations you wish to do and what are the investigation reports?
One is those estrogen, LH, FSH, those even thyroid profile.
Okay.
To look for HP excess, either hyperactivation or
Okay, if you have.
investigation
So
done.
why you do LFT and the interpretation you can go on saying. Why we have to do LFT and
chronic liver disease is associated with a bilateral the gynecomastia.
during MBBS you would have read, right?
Yes.
Cirrhosis of liver comes with the gynecomastia because of estrogen excess. That applies here also.
Chronic liver and kidney disease both can be associated with gynecomastia, and as you rightly pointed out, is usually bilateral but maybe unilateral.
And other hormone levels, estradiol, it is less than 10 picogram per ml, it is normal. Testosterone less than 2.5 nanogram per deciliter, it's a lower limit. Beta HCG, it's 0.6 milliunits per ml. LH is 0.32 units per liter and FSS is 0.67 units per liter. T4 is 139 nanogram per deciliter. TSH is 2.1 micro units per liter. Almost all the investigations are normal.
Okay. Another investigation that can be done, I mean, yes, you are showing me that. The next slide is classifying the type of glandular tissue in the breast region. Yeah, whether it is active proliferative or whether it is quiescent or chronic in nature. That will also help you understand as to how long standing has the process been and what is going to be the amenability if you try to address it with pharmacotherapy.
Scrotal USG, which is done on 4th of April 3rd, which is partially descended right testis located in the inguinal area. And USG left breast, a few ill-defined ductal tissue noted in the retroareolar region, no internal cystic lesion, suggestive of gynecomastia.
The previous slide, the LH was 0.32, just the puberty has just started.
Yes.
It is not the mid-puberty which sir says, and even it has started only in the blood. Okay, it is just the pulses have started. Clinically, we don't have any evidence of puberty because testicular volume is still 2 ml. As sir said, it is the initial of puberty that may not be still, could be pathological, could be even physiological part. And thyroid, as it is normal, because what happens in hypothyroidism?
The TSH level will be elevated.
So what happens?
It's a reactivation of that HP axis is hyperactivated.
FSH, TSH share an alpha subunit which is common. So when you have very high TSHs of more than 150 MIU per ml or beyond, then there have been cases of spillover and activation of the other hormone receptors, leading to changes of pseudopuberty. That is, that is why girls may come with discordant vaginal bleeding in severe cases of primary hypothyroidism. So similarly, some may present with gynecomastia. But doesn't seem like in your case the TSH is normal. No. I would be concerned with the LH of 0.3 because at 9.5 I wouldn't want the LH to be detectable. But what is going to be important here is what is the limit of detectability of the assay that has been used to measure the LH. Because in India we have many centers where the limit of detectability could be as high as 1 MIU per ml. So in those, this is insignificant. It is undetectable. Whereas if you're using a next generation or a third generation ultra sensitive assay, then the level of 0.3 signifies that there have been onset of secretory pulses, as Dr. Shaila mentioned.
And estrogen is undetectable, but I don't know, it could be there. But even 15 or 20 picogram means there is a estrogen which is causing. Testo is not there. So why, if it is a pubertal thing, in a pubertal gynecomastia, why the gynecomastia occurs? Otherwise, why gynecomastia occurs? Any reason for the gynecomastia to occur?
So one release of estrogen,
Yes.
in turn causing the ductal tissue enlargement, proliferation, which is causing the gynecomastia.
Okay, to summarize, any estrogen excess or the androgen deficiency can come. The imbalance between the androgen and the estrogen can come with the gynecomastia, which occurs even in neonatal period, comes as a neonatal gynecomastia. During puberty, initial to mid stages, when the androgens are not so high, estrogen conversion will be there. That can come as a pubertal gynecomastia. Over the ages, in the older age, and as the androgens comes down, because of the increased conversion to estrogen, they come with the senile gynecomastia. And in Klinefelters, which I asked you, the social milestones, there also the androgen deficiency will be there. That can come with the gynecomastia. Or liver disease, excess estrogen is coming. And we discuss about the familial thing, hyperaromatase enzyme. Aromatase enzyme, which is what it does, it converts the testo to estrogen. If there is an enzyme deficiency, which enzyme hyperactive in the family, there will be familial history of gynecomastia because of the excess conversion of testo to that they just come with the gynecomastia. No other issues will be there. And you did for the beta HCG. Any reason for beta HCG? That one, I think it will end the case.
One is teratomas, is either ovarian tumors, is associated with the increased production of the estrogens in associated production of beta HCG, increased synthesis of beta HCG.
So want to say.
So HCG secreting tumors cause gynecomastia. They can be present in the testes. Their incidence is higher if the testis is an undescended one, or they could be present in the liver, or even germinomas could cause HCG secretion and gynecomastia.
But here in this case, nothing was there. I think the only thing is we can console them and giving some temporary medication, like as the child is had on some tamoxifen, I think. That
Generally, in an idiopathic prepubertal gynecomastia, the drug preferred is aromatase inhibition. Now, selective estrogen receptor modulation or tamoxifen citrate, which is the drug of choice for pubertal gynecomastia. So, as Dr. Shaila was saying, heightened sensitivity to the low circulating estrogen during puberty, which is not as low as in the prepubertal phase, and accelerated aromatization are the reasons why boys develop gynecomastia during puberty. And during mid-puberty, the concentration of testosterone is high enough to have adequate aromatization. So their selective estrogen receptor modulation works better, or tamoxifen citrate works better. But when you do not have high levels or detectable levels of sex steroids either, then aromatase inhibition with variable efficacy is usually offered as the first line of therapy. Also, certain genetic syndromes can cause prepubertal gynecomastia. So we should look for mucosal hyperpigmentation, any gastrointestinal history like bleeding or hyperdefecation, and look for any variable cutaneous pigmentation to find an association or a clue with the prepubertal gynecomastia.
It's not fixed. I didn't touch him, but it was not looking actually. It is not this.
Thank you, Malam Gowda. It was a crisp and sharp and concise presentation. Now I call upon Dr. Nischita Bellar, Junior Resident, JNMC, Belgavi, for case presentation.
Very good afternoon, everyone. I am Dr. Nishita Bellar, a junior resident from JN Medical College. Will be presenting a case of precocious puberty under the guidance of Dr. Shaila Pachapur ma'am. Coming to the case, the child presented on 8th of September 2022 when she was 2 years 6 months of age, female child, resident of Gangavati, informant being the mother. She had history of presentation of vaginal bleed. First episode at 1.5 years of age. Second episode 3 months later, and followed by every month for the last 5 months. The mother noticed breast enlargement, for which duration was not known. Weight gain and height gain was also noted. Coming to the negative history, there's no history of convulsions or laughing episodes, vomiting, headache, aggressive behavior, visual disturbances, or head injuries in the child. Coming to
the HOPI, so the complaints are of
vaginal bleed, ma'am, since 1.5 years of age.
And
breast enlargement, the duration is not noted by them.
Okay, the third is weight and height gain. So what you diagnose at the end of this thing? It's a case of?
Precocious puberty.
Okay, fine. So the age of onset is something around 1.5 year of age. Okay. But why you ask the negative history in that condition?
To rule out any CNS causes for any tumors or any visual gliomas. To rule out any gliomas or any seizure disorders in the child. Any head injuries present which may cause.
As we know, pituitary is located in the center. Anything related to the seizure part or anything related to the vision has to be asked, or in signs of raised ICT. Okay.
Coming to the birth history, the child is second order born child to a non-consanguineous marriage. Family history is not significant. Birth history was normal. Child was born by LACS, 2.5 kg birth weight. No history of NICU admission. Child has achieved developmental milestones appropriate to age. Immunization date is as per national immunization schedule. Mother's menarche age was at 14 years of age.
Yeah. Any case we have to ask for the maternal menarchal age. Okay. And it is too early for the child to compare even the maternal menarchal age here.
Yes. Okay. Coming to examination, child is an active child, vitally stable, normal vitals or febrile. Coming to anthropometry, at 2 years 6 months of age, weight observed was 18.2 kgs, expected is 13 kgs. Inference, it is more than 97 centile. Standard deviation of plus 2.7 is seen. Height is 98.2 centimeters. Expected is 92, more than 97 centile, plus of standard deviation of plus 2.13 is observed.
We usually get 100 centimeter at what age?
Sorry, ma'am?
We get 100 centimeter at what age? Usually by?
5 years of age. Sorry.
When height doubles, length doubles? 4 years, right? So the child is 2.5 years and height is almost like a 4-year-old child. So what mother said, they have noticed increase in the height.
Yes. Mid-parental height is up to 154 centimeters.
Show the growth chart and okay. So explain that.
Mid-parental height will come up between 5th to 25th, 50th centile, the child is already 98 centimeters, which is more than 97 centile of.
So the interpretation is
Height is affected. Height and
there
weight
is
both
a
are more
height
than.
spurt. Any child, we don't know about the previous height recordings, but if you have the recording since the birth, we'll know there is a sudden height spurt in the last 1 year or 2 year prior to the presentations.
Yes. Coming to examination, 2 caphioly spots were observed less than 1 centimeters, one on the chest and one on the left thigh. Sexual maturity is B4, P1, A2, M1. Vaginal mucosa is pale, which is indicative of estrogen in the body.
Okay. Can you explain why we had to see for caphioly spots?
To rule out any it is a neurocutaneous marker to rule out any Macu-Albert syndrome.
Which neurocutaneous, whatever conditions, can cause precocious puberty?
Macu-Albert syndrome can.
Okay. Macu-Albert syndrome, does it come with the CNS symptoms?
CNS system will not be there.
Which other condition we examine for the this one, caphioly spots?
Neurofibromatosis.
Yes. Why neurofibromatosis? We had to see the precocious puberty.
Cause gliomas, which can cause
precocious puberty. So any tumor sitting at around the pituitary region, we have to see for the thing. Next.
Systemic
SMR?
examination is normal.
Okay.
SMR staging, breast enlargement is 4. B4, P1, A0 and M1. Vaginal mucosa is pale.
And for the benefit of PGs, B1 is prepubertal, B4 is like a secondary mount, and it was like primary mount and followed by having a secondary mount. That is almost imminent with the menarche. P1 and A is not there. There is no pubic hair, and I think axillary is also not there.
Yes.
M we take M0 or M1. No menarche, menarche. That's only 2 words there. And vaginal mucosa, as she said, it is pink means non-estrogenized. Pale means estrogen has come. Okay, systems are normal as per you. So the diagnosis?
Precocious puberty, mostly central cause, probably a hypothalamic hematoma.
So why you think it is a central cause here?
There is growth and height is affected, ma'am, for the child.
As I said, any hormones, male hormones, if they come early, they can cause a height spurt because they advance the bone age. But here to know the central cause, consider the age. The child had precocious puberty at what age?
2 years, 6 months.
Okay, normally when the puberty should occur in girls, we discussed earlier.
9 years, 8 to 9 years. 9 years to
13 years. So when we say precocious puberty?
Less than
8 years of age. And the child had precocious puberty at around?
2 years, 6.
Almost like 1.5 to 2 years. At this age, the most common DD for presentation as precocious puberty is?
Central causes.
Hypothalamic hamartoma. The next being, which we discussed already. Precocious puberty can occur at various ages. As earlier the age, the most probably the hypothalamic hamartoma is the most common cause. Second being the Macu-Albert syndrome. But what is the triad of Macu-Albert syndrome?
Fibrous dysplasia of the bones.
Okay, they will have a bony deformity. Next, may or may not be having clinically. Next,
precocious puberty will be there. Skin manifestation of more than one side of the body will be involved.
Caphioly spot. That is why any case of precocious puberty, we look for the caphioly spots. One is caphioly spots. One is a fibrous dysplasia. What is the third component? Precocious puberty is not the only component of that. Anyone have the idea why Macu-Albert syndrome occurs? PGs. You all are aware FSH, LH, TSH, they act on the G protein coupled receptors, right? That alpha receptor is mutated here. It becomes hyperactive. That causes hyperactivation of alpha receptor. So FSH axis gets activated. That comes as a precocious puberty. If it's activated in the TSH, it comes as a hyperthyroidism. If it gets activated in the ACTH, it comes as a Cushing syndrome. So it's a hyperfunctioning of the G protein coupled receptor thing. So caphioly spots, that is why when we have a case of precocious puberty, we have to look for the caphioly spots. Along with that, hyperfunctioning of the thyroid gland, or is it a child comes in Cushing's? Many of the time child comes in Cushing condition. As we share the caphioly spot, they have on the body, it doesn't cross the midline. It respects the midline. Many of the time you see such a big caphioly spot which is not crossing the midline. One thing, and they would have come with a Cushing syndrome. not all the hyperfunctioning will be seen. So the purpose here is just to see for the Kefali spots, that's it. Okay, next. So clinically she has diagnosed it's a case of central precocious puberty, but we don't know whether it's central or peripheral still.
Coming to investigation.
And at that less than 3 years, macune and hypothalamic hamartoma is still the most common. Over the ages, other conditions will come. So considering the age, we have to think of these two things.
On X-ray, the bone age is 4 years, 5 months age, with Tanner White's class, stage 3 evaluation. Chronological age of the child at the time of presentation was 2 years, 6 months.
So what the bone age says at the chronological age of 2 years, 6 months, the bone age is?
2 years more, 2.5
So what
years
it says? Bone age is advanced. So there is a height spurt along with the bone age. So clinically, you know the child has got precocious puberty. We have plotted on the growth chart. Growth chart is an important part. And along with that, you did a bone age, which proves that child has advanced puberty also. Yes. The bone age is advanced. Next.
Coming to investigations, hormone assay is done. LH was elevated 3.6 milli international units per ml. Normally it should be less than 0.3 milli international units per ml, which is indicative of central cause of
Why you say it is a central cause?
Precocious.
Why you say it is a central cause of precocious puberty?
LH is elevated, ma'am, with
what is the normal axis of pubertal thing?
GnRH stimulates LH and FSH, which will act on the gonads to stimulate the hormones.
Okay, so what it stimulates? It stimulates the ovary to produce
estrogen. And
what it does? What estrogen has an effect on the body?
Development of secondary sexual characters.
Okay, so it causes?
Breast enlargement.
Yes,
in
it
females.
causes the breast enlargement. It causes?
Menarche.
Uterine enlargement. The uterus become estrogenized and they comes with the pubertal. So, but for the pubic hair and adrenal hair, is the FSH-LH axis is required or anything else is required?
Adrenarche is required.
Yes, adrenal axis is the one which takes care of the pubic and the axillary hairs. For the GnRH axis takes care of the ovarian development, which causes telarche, and also the uterine enlargement, which comes as a menarche here. So LH confirms it is a central cause. Next. Okay.
We have done a USG abdomen and pelvis, which showed enlargement of the uterus. Right ovary volume has increased 1.6 cc with 3 to 4 follicles. Left ovaries had 1.8 cc with 6 to 8 follicles present.
Okay. So as we discussed, in a case of precocious puberty, we have to prove. Clinically, we know the child has got advanced height. So we have to prove by bone age. So here bone age is advanced. And we have done investigations which is suggestive of central cause. But ultrasonography also you have to document. So what you ask the sonologist, you cannot send, it's a case of precocious puberty, please look into the uterus. You have to ask some 4 points in that. We always mention in that and send. What is that 4 points?
Uterine development, if it is
uterine size. Normally less than 36 millimeter or 3.6 centimeters. Here it is advanced. Then
endometrial thickness of body to cervix ratio.
Yeah. Then normally how is a prepubertal uterus? It is not usually seen and it looks like a tubular. If it is a puberty, it becomes like a pendular. And the body to cervix ratio becomes
3:1.
Yes. It is 1:1. The uterus body is also small, the cervix is also small. It is 1:1. If it is a puberty has started, it will become 2:1 or 3:1. So we ask the sonologist to look for uterine size, body to cervix ratio, endometrial thickness, what it says?
Any cycles, if the
yes,
child
it
is on
exposed to
menstrual
estrogen.
cycle.
3 millimeter means it is exposed to estrogen. 5 millimeter means it is imminent menarche. She can have periods now. So we have to ask that. And ovarian size in cubic millimeter. They always give 1.8 into 2. We ask in 3 dimension and ask for the volume. Usually more than 2 cc they take it as an. And there are follicles. Follicle says FSH has acted on the uterus, ovary.
Coming to other investigations, electrolytes were normal, urea and creatinine was normal, calcium and phosphorus also was normal, TSH also was reported as
the
normal.
The purpose of doing TSH in this case?
Ma'am, if there is an TSH can act on as FSH and stimulate the axis as well in some
So what is it is called as?
um,
We said, right? Any hypothyroidism, prolonged hypothyroidism, TSH mimics like an, TSH will be elevated, that mimics like an FSH, that stimulates the ovary and can come with the precocious puberty. But here the axis is not activated. It is not the GnRH, FSH-LH axis, it is the hypothyroidism coming as a precocious puberty. So what is the difference between normal, regular puberty and hypothyroidism induced puberty? What hypothyroidism causes? Till now we heard about that. Hypothyroidism causes what they can come with?
short stage.
Yes, precocious puberty comes with a tall
Taller.
stature. So any case when the child comes in puberty, the growth chart will tell the child is short or tall. If child is short, we think of usually hypothyroidism. Because of the high TSH mimicking like an FSH, causing a ovary to stimulate so that it will have a telarchy. Within 1 year they come with the menarche. It's an hyperestrogenic state. So it is a case of peripheral precocious puberty where the central axis is not activated. It is called as 1 week Grumbach syndrome. So many cases are there, they come with the periods but the child is short. Any short child, think of hypothyroidism induced precocious puberty.
MRI was done since the age of the child was less than 6 years of age, which showed fairly well-defined intra-axial lesion likely arising from the tubular cinerum located between the mammillary body and optic chiasma on the left side of the
So can make out in the initial when we asked for the MRI, they said it is normal. But when they said please look for the hypothalamic hamartoma, then they looked and there was a hypodense lesion that they had missed initially. They told it is normal because picking up of an hypothalamic hamartoma is an important lesion because we know it is a case of central precocious puberty and it is a case of hypothalamic hamartoma because the age of presentation is less than 3 years. So we again asked for the radiologist and they said it is there. So please talk with the radiologist regarding the uterus size also. Show the other images also. It is not clear here, but it was there in the first image. That hypodense lesion which they have marked is a case of size of around just 1.2. Go ahead.
Yes.
Go ahead.
This suggested that this was
The final diagnosis is?
central precocious puberty secondary to hypothalamic hamartoma.
Okay, fine.
Treatment GnRH analogs were given for the child, 11.2 mg deep IM injections every 12 weeks till 11 to 12 years of age.
So why we have to give a GnRH analogs in this condition?
It will, there is no pulsatile release of GnRH which will decrease the FSH and LH, which will stop the LH and FSH release from the
Normally
CME.
FSH-LH comes in a pulsatile secretions. When we give this analogs, it has a long depot action. It suppresses the GnRH axis and we can postpone till we want it. We can postpone till the normal age of pubertal onset. Because child is just now 2 years. What will happen if we don't give the treatment to this child? GnRH analogs. She ends up being, the bones may get fused and she ends up being short. Even though there is an initial height spurt, but she ends up being short. That's the one aspect. And the age of, she's just 2 years and we cannot imagine them having a periods. It's a psychological, even now we are getting a lot of first standard, second standard kids coming with the precocious puberty, and the one of the main reason to postpone their puberty is for their psychological effects. That's the important part. Okay.
Follow-up, the injection is given on every 12 weeks. Breast tissue has softened. The child stopped having periods after 2 cycles of GnRH analogs. Presently, the child's weight is 29.7 kgs, which is more than 97 centile. Height is 144 centimeters, more than 97 centile. There are no aggressive behavior or galactic seizures.
What are the clinical features of hypothalamic hamartoma? Laughing seizures or the gelastic seizures or the Some can come with the aggressive seizures. We know it is a case of hypothalamic hamartoma and we have to have a follow-up because they can come with the seizures. So can we do surgery for this child? Because we know there is a hypothalamic hamartoma. Should we do surgery rather than giving leuprolide acetate?
No, ma'am.
Why not?
Ma'am,
Why
since
we shouldn't be doing?
it is not a neoplastic lesion. Hypothalamic hematomas are a focal malformation resembling, but is not a neoplasm. It is not a significant tumor. It is normally found in the area. Just disorganized mass is seen. Unless there are CNS symptoms, we can.
There are two types of hypothalamic hamartoma. One is a there are two types. One can just come with the refractory seizures, which we had seen during our fellowship, and there the indication has surgery because we had to take it out. If it just comes with a CPP, no need of surgery, but you have to monitor for that. So it is not an indication for surgery, but we have to counsel parents whether child has any aggressive behavior. That's the thing. Otherwise, it's not an indication for surgery. It is not the tumor like optic glioma and all that which is going to increase. Okay, fine. Go back. I think we'll explain. Just explain the slide and I think we'll end the class. Next slide.
Normal age of puberty seen in girls. Telaki is the first sign seen between 8 to 13 years of age. Boys, testicular volume increases more than 4 ml, seen in 9 to 14 years of age. Hypothalamic hamartoma, as explained before.
So the first sign is telarchy, and when they have menarche, usually
2 years after the
2 to
onset of
2.5
telarchy.
years. When you say it's a discordant puberty,
Within 1 year of telarchy, if the child has menarche.
if mother notices a telarchy within less than 1 year, if she has periods, it is discordant. It shouldn't happen. Normally it's a gradual process. Estrogen builds up and then they have periods. If it is less than 1 year discordant, it should not happen beyond 5 years also. That is called as delayed puberty. Recently had one case, the child had come, all the sexual characteristics were there. She came at 15 year 10 months with no periods. She came with primary amenorrhea. She had all the secondary sexual characteristics, pubic hairs where everything was there. So what could be the cause? Even though she has a FSH, LH, everything, but she didn't present in menarche. End organ. Uterus was not there in her. Mayer-Rokitansky syndrome. This one.
Right.
So that can come. So more than 5 years, more than 15 years, if she doesn't come with a menarche, that can be taken as a delayed menarche. So testicular volume, we all know which tool we use to measure testicular volume. Orchidometer, we have to measure testicular volume, and more than 4 ml is the
increase in volume of
yes, that says the puberty has started. And clinically it is not easy to measure because usually girls do come with the telarchy presentation, boys it is difficult. Many of the times we are getting many mothers coming telarchy at 6 years and 7 years and they are getting their periods in the 3rd standard. So please convey them, we can postpone their puberty till whatever age they want, because to preserve the final height. That's the main important thing. Here the child has got underlying condition, but otherwise between 6 to 8 years, if the child comes in a precocious puberty, there won't be any other causes. Less than 6 years, we have to look for the CNS causes. Any girl coming less than 6 years with precocious puberty, please do an MRI to note any underlying conditions. More than 6 to 8 years, it is idiopathic, maybe because of our some food habits and all that. Lot of estrogen, phytoestrogens which are added in the food. Many girls are coming with a precocious puberty. But in this case, if it happens in a boy, we have to do an MRI at any cost, because boys have a more of organic causes than girls. So MRI is a must. Or anytime any child has a CNS symptoms, MRI is a must. Done, no?
Central precocious puberty presents early as 1 to 2 years of age. Patients present with precocious development of physical changes associated with puberty. Neurological problems like epilepsy may be absent. MRI is typically seen in these lesions in the anterior location of the hypothalamus. In case of epileptic type, galactic seizures is the first symptom often occurring during infancy, associated with developmental delay, cognitive deterioration, and psychiatric symptoms. MRI, the hematoma would be present on the posterior part of the hypothalamus. Management, GnRH analogs can be given in precocious puberty. In seizure type, anti-epileptic are less successful in controlling seizures associated. Surgical treatment is required in these type of cases.
So, but here any case which comes to the precocious puberty, try to see whether it has come from center or periphery. If FSH, LH are suppressed and we are getting testo or estrogen, look the three organs, testis, ovary and the adrenals. Ask the sonologist, is any tumor? If boy is coming with the gynecomastia, ask any Sertoli cell tumor is there or adrenal tumor is there. If girl is coming with the virilization, which we ask clitoromegaly, hirsutism and all that, ask for adrenal tumor, it could be CH. Recently we got one more case from SDM where the child had come with a clitoromegaly of 4 centimeter and she had only pubic hairs, no telarchy, which we say telarchy is a first sign of puberty in girls, but she came with the male hormone excess. So there was no breast development. It is a peripheral precocious puberty, but it is not isosexual, it is heterosexual. Isosexual means it should have their own thing. Activation of GnRH axis, FSH, LH, estrogen. If a girl is having male hormones, it is heterosexual precocious puberty. So the investigations, clinical examination is an important part where you will come to know whether is a telarchy is there, no telarchy, only male hormones are, means only adrenal androgens are coming and it is causing a virilization. Please look into the adrenal gland or ovarian tumors. So it depends on the clinical examination is an important part. The boy is coming with a gynecomastia. So look for the estrogen hormone excess. Girls coming with the male hormone excess, they come with the secondary sexual characteristics rather than the telarchy. So the examination is an important part and relevant investigations based on that.
Thank you, Nishchita. It was wonderful presentation. It was comprehensive and well structured. Now I'll call upon Dr. Jhansi for the next presentation.
Good afternoon, ma'am. I'm here to present a case of 2 year 6 months old boy child, Aryan, who's come with complaints of increased penile length and scrotal volume noticed by the pediatrician at the regular follow-up at 11 months of age, and mother noticed that the child is taller than the peers at 11 months of age, for which he was referred and evaluated for the same. He didn't have any complaints of change in the voice, any complaints of axillary or pubic hair. He did not have any history of vomiting, headache, irritability, no history of trauma. His birth, he otherwise has no previous hospital admissions. He was born to a non-consanguineously married couple and with a birth order of 6. Mother had 4 abortions. One was medically terminated electively. The other 4 was missed abortions, all of them in the first trimester. Cause unknown. And for his pregnancy, she had undergone ovarian induction. The time of ovarian induction, and she was started on tab progesterone for the first 6 months of her pregnancy. Otherwise, she had no significant antenatal history. The child was born via full-term vaginal delivery with birth weight of 3 kgs and had no significant neonatal history. History of hypothyroidism present in the paternal aunt and the grandmother. Otherwise, no significant family history. He was developmentally normal child, and yes, ma'am, developmentally normal child.
So
On examination,
it's a briefly positive is 2 year 6 months child
2 year 6
with
months child.
penile enlargement and pubic hairs.
Yes, ma'am.
Okay,
and a height spurt.
Height spurt.
Only positive history is that in that.
Yes.
So preterm 3 kg unlikely to be, could be term 3
Term
kg.
baby. He's
Okay,
a
fine.
term child.
Okay, fine. So there's a precocious puberty case.
Precocious
Okay.
puberty. So when at admission on examination, his height, ma'am, he had no neurocutaneous markers. He did not have any. His SMR staging was prepubertal, with the testicular size measuring on ultrasound. With the testicular volume. Clinically, it was less than 4 ml. And then he had no pubic or axillary hair. Other system examinations were all within normal limits. Anthropometry, his weight was 13.5 kgs, 13.7 kgs with observed weight of expected weight of 13.5 kgs. So his height was weight was at 50th centile. Height was 93.6 centimeters with the expected height of 86. So his height was between 50th to 75th centile. And BMI was at 50th centile. So he did not have any.
Always compare with the mid-parental height. We know there is a height spurt.
His expected height is 166, ma'am. His mid-parental
So
height.
always show it in the growth chart. The child is being tall compared to the parents. Okay. Next.
On investigations.
No. The child is a case of precocious puberty. I don't know that the child has got height spurt, but testicular volume is
increased.
Prepubertal. So what is the diagnosis here?
It looks like
it's a central precocious puberty or a peripheral precocious puberty. The first thing.
It looks like central precocious.
If it is central, testicular volume has to increase. Because we discussed earlier, the 2/3 of our testis is made up of Sertoli cells and 1/3 is of Leydig cells. If there is an axis stimulation from center, there should be testicular volume increase. It is not there in this case. So it is a central or peripheral precocious puberty?
Peripheral precocious puberty.
Okay, peripheral precocious puberty. And in the peripheral precocious, is it isosexual or heterosexual?
Isosexual.
Because child doesn't have any gynecomastia. Child has only have just excess
testicular
hairs.
enlargement.
And there's a height spurt.
Yes.
So it's a isosexual peripheral precocious puberty. Okay. Now tell me what you want to do the investigations in this case.
For him, like you had already told, ma'am, for all boys less than 5 years of age, we need to rule out central cause. So we need to get.
No. I said less than 5 years of age, we have to rule central precocious puberty. But for that, you should have the clinical features also. Here, testicular volume has not increased. As you say, there is no telarchy. Telarchy is a must for girls. Here, there is no testicular volume is not increased. So we cannot take it as central precocious puberty. It is a peripheral precocious puberty. And in that, we have to see where is the origin of the hormones which is coming.
We have to look for the hormones and testosterone.
Yes.
And
so first thing is bone age. We know there is a height spurt. We want to know where is the bone age, because that is important. Because once you start the treatment, we should have a baseline bone age to compare. Bone age shouldn't advance too fast to cause a short stature. Our concern again as an endocrinologist, growth and development. Still, growth and development is an important aspect. The growth chart is an important. Still, we are a pediatric is a part of things.
His bone age at 11 months of age was 24 months, ma'am.
24 months. Okay, fine. So did you go the investigations? What you want to look into that and next. Okay. Thyroid is 8.9. It's okay. Till 10 we take it as a normal in that age group, and she said it's a normal developmental milestones. 17 OHP. Why you do 17 OHP in this case?
To look for all the.
We discussed, right?
CH.
CH. Why do they come with ambiguity in this age in 21 hydroxylase? 21 hydroxylase doesn't come with ambiguity, but they can come with the peripheral precocious puberty with the normal prepubertal testicular volume, and 0.9 is normal. Okay, next. LH is 2.36. LH says what?
That there is, if any detectable LH is central cause of precocious puberty.
So different assays are done. In our thing, we are doing a bit by CLIA method, chemiluminescence assay. They may take 0.2 or 0.3 as a cutoff, because we are doing a higher immunoassays are being done everywhere, even in SDM also. 0.2, 0.3 can be taken as a cutoff, and 2 is definitely significant. But 2 says it is central precocious puberty, but that doesn't go hand with your testicular volume.
It's less than 0.2, ma'am. LH is
at 11 months, it was 2.36.
Huh, ma'am. It was repeated again in 1 year, 1 month of age.
Okay, fine.
That time it was less than 0.22.
Okay, so there is no LH, no FSH. But what is coming?
Testosterone.
But that is not so high. 18 is okay. More than 10 we take it as a cutoff and it is coming. Okay. DHEAs it is. Then?
Only thyroid is elevated, ma'am, marginally. 10.
Borderline TSH, it is not so much to cause. As we said, one more thing. We say the testicular volume has to increase for the puberty to occur. Central precocious puberty. Because the FSH-LH stimulates. In TSH, whenever someone has got a high TSH, not 10, very high TSH, it mimics like an FSH, stimulates the ovary. Similarly, it stimulates the testis, FSH-like action. It causes increase in the testicular volume, but not so much it occurs in a central precocious puberty. Only Sertoli cell compartment is stimulated here. So that slightly little enlargement of the testicular volume, not so which occurs in central precocious puberty. But TSH of 10 cannot cause such stimulation of, almost you are saying the lot of pubic hair is coming. 10 may not cause that much of things.
Otherwise, all of the hormone assays were normal for him, ma'am.
So testosterone is coming, 18, borderline. It is not matching. So what are the causes of peripheral precocious puberty apart from?
It could be congenital adrenaline hyperplasia.
Yeah, 17 OHP is normal.
Adrenal tumors.
Yes. So what we do? DHEAs.
DHEAs
we do for adrenal tumors and testosterone. They'll be not been in just like 18 and they'll be in 300 and all that. DHEAs will be around 1,500. We had a case. It was more than 1,500. More than 300 it will be there. Microgram per DL. Total testo will be in hundreds. It can't be in 18. So there is androgen is coming, but there is no proper evidence in the investigations. It is not supportive. So 17 OHP, as per this testo and DH is not supporting, I think we have to go with this ACTH stimulation test to see whether it's still a CAH. Because it's a very borderline case, I think that's the thing. Any USG finding is there?
Yes, ma'am, USG was done.
Okay.
But USG abdomen was normal.
There is no any marker of this one?
Nothing.
Otherwise, just go ahead with a repeat testo and DHS at a better lab because there are only two causes here. Because testicular volume is 2 ml, we have to have a look where the testosterone is coming. And we know, as you said, adrenal gland. Adrenal gland is not enlarged. If it is a tumor, it will come. If it is not enlarged, CH is a possibility that just comes as a hyperplasia. So in that condition, you can do ACTH investigation test. Or testis, you ask the lab scan to see for any tumor in that. Any unequal tumor is there. Leydig cell tumor can come like that. So bilateral equal enlargement of testis during puberty is a CPP. Slightly increase in testicular volume but not congruent with the pubic hair is Sertoli cell tumor or a hypothyroidism. Unequal testicular tumor could be Leydig cell tumor. Less than 2 ml peripheral precocious puberty. So testicular volume examination is an important part in this condition. But I think we should go ahead with the repeat TSH, testosterone DHEAs. Because as you say, LH is not there. There is some testosterone which is coming here. Last one is HCG secreting tumor. That has to be looked into that. And one more case, the similarly case, child came with same, less than 1 year old child came with peripheral precocious puberty. LH, FSH was very much suppressed because there was some male hormone was coming and ultrasonography revealed a hepatoblastoma. And AFP and HCG were more. HCG also stimulate like an FSH, stimulates the testosterone production. So it is just the male hormones are coming, but not from center. Hepatoblastoma. So the scan is an important part, and even HCG secreting tumor has to be looked at. I think we need to repeat the test 20 HCs in this case. I think a lot of cases.
Thank you, Jansi, for such an informative case presentation. I really like to thank our esteemed judges for your time, insights, and thoughtfulness, and the discussion. We truly appreciate your support and expertise. We are truly indebted to you, ma'am. Next, I call upon Dr. Lavanya for physiotherapy, who is a physiotherapy postgraduate, to deliver the next lecture.
Good afternoon, everyone. Am I audible? Yes. Good afternoon, everyone. Here I am standing, myself, Dr. Lavanya, PT, a senior postgraduate from Pediatric Physiotherapy Department. I welcome everyone for my talk. I think everyone might be hypoglycemic, even I am little bit of hypoglycemic right now. Now we will study about hyperglycemia. As we all talked lately about precocious puberty, other pediatric endocrinology diseases and disorders, now we will talk about type 1 diabetes mellitus and how exercise has its own importance in management of type 1 diabetes. Now, juvenile diabetes, also known as type 1 diabetes mellitus, it is a chronic metabolic disorder characterized by high plasma levels of glucose resulting from defect in insulin secretion, action, or both. Now, in type 1 diabetes, autoantibodies of oneself attacks the beta cells in the pancreas, affecting it to synthesize in the insulin in the pancreas. Now, type 1 diabetes accounts for the 10% of the whole total diabetic cases. Globally, the incidence being 15 per 1 lakh kids, and in Karnataka, prevalence of type 1 diabetes being 17.3 per 1 lakh kids. Average onset is in childhood, early adulthood, usually before the 30 years of age. As we are seeing, the incidence and prevalence has been increasing year per year. Now, clinical features, even though there is high levels of blood glucose in the blood, the child is the glucose is unable to enter the targeted tissue due to lack of insulin. Insulin is an anabolic hormone. Deficient in insulin causes the child in the catabolic state. In the catabolic state, the body uses fat and proteins for the energy production. Derived of the glucose, the tissue goes in the tissue starvation, leading to weight loss and increase in appetite, polyphagia, and after high levels of blood glucose, the kidney is unable to filter the glucose or reabsorb the glucose after exceeding the glucose threshold. Some of the glucose spills into the urine, leading to glycosuria, and glucose is osmotically permeable. Water also follows with it, leading to polyurination or polyuria. Then due to excess urination, the child is dehydrated, leading to polydipsia, and we also see due to tissue starvation there is fatigue and weakness in the child, and also slow healing wounds. Now, what happens when we don't manage the type 1 diabetes regularly? Now, in the catabolic state, now the body is using the fat for the energy production, and also there is increased levels of glucagon in the body, which increases the lipolysis. During the lipolysis process, there is increase of ketoic acid when the body uses fats for the energy production. This changes the pH levels of the blood, making it as a metabolically acidic. Initially, it is compensated by our body, converting from using up the electrolytes. Later, when the body is unable to compensate, the body becomes metabolic acidic, which leads to diabetic ketosis, which is a very major emergency state of seen in the type 1 diabetes children. Now, and chronic exposure to high levels of blood glucose leads to diabetic neuropathy, nephropathy, and retinopathy, leading to cataract and blindness, heart and blood vessel disorders, and atherosclerosis secondary to abnormal lipid metabolism. Now, the first line of diabetes management is insulin, as the child is deficient and lack insulin. Then following a healthy diet, that means low carb diet and regular exercise or physical activity. Even though how exercise lowers the blood glucose levels. Now we always know after having a carbohydrate rich meal, we always there is rise in blood glucose and it enhances the pancreas to release the insulin into the blood. Insulin takes the glucose to the target cells, binding to the tyrosine receptors and absorbing the glucose from the bloodstream. Due to lack of insulin, the child will be hyperglycemic. Now the tissue is starving, like fasting state of the body. Now how exercise will emphasize? There are two mechanisms how exercise increases the glucose uptake from the bloodstream. One is insulin signaling pathway and one is contraction mediated pathway. In insulin signaling pathway, even with a minimal insulin, how the child can benefit the glucose uptake. In contraction mediated pathway, how intense exercise helps us to absorb the glucose. In insulin signaling pathway, when insulin binds to the tyrosine receptors, there is auto phosphorylation cascade initiated. It activates proteins by donating one phosphate group. Activated insulin receptor recruits its substrate IRS1. It catalyzes phosphorylation of phospholipids, making the lipid layer of the cell very permeable to glucose. And also this PIP3 phospholipid 3 recruits protein kinase B. Protein kinase B phosphorylates TBC1D1 which activates the RAP GDP at the cellular compartment level, releasing the GLUT4 vesicles to the surface where the glucose uptake can be done. Now this is insulin signaling pathway. It works better in the type 2 diabetes where they have insulin resistance. In type 1 diabetes where there is lack of insulin, where insulin is administered from the outside, here we can go along with the contraction mediated pathway. During intense exercise or heavy exercise, enzyme for the energy, enzyme called adenyl kinase converts 2 ADP molecules into one ATP and one AMP molecule. The one ATP molecule can be used for the immediate energy, and one AMP molecule attracts AMP activated protein kinase. This AMP activated protein kinase plays a similar role of protein kinase V, which phosphorylates the TBC1D1 proteins, which again activates RAP GDP proteins in the cellular level, which enhances the release of GLUT4 vesicles to the surface. And also calcium released during the contraction from the sarcoplasmic reticulum also promote GLUT4 vesicles translocation. This is how exercise enhance the glucose uptake from the bloodstream. Now my study is on the type 1 diabetes to see the effectiveness of exercise. The even though it has been emphasized and encouraged by the pediatricians, the parents do not follow, or the child is very weak, or like they do not meet the exercise needs or the physical needs. Many families do not follow the recommendation, and the children and adolescents should spend in 60 minutes or more of physical activity daily. Therapists can play an important role in assisting families with this challenge, as physical activity benefits the managing the diabetes. Regular exercise improves glycemic control, general health management, and psychological well-being of the child. Now, the aims and objective of my study was to see the effectiveness of concurrent training of resistance and aerobic training on glycemic control on type 1 diabetes, and also to see improvement in their pediatric quality of life in type 1 diabetes children. My outcomes were glycated hemoglobin values, which will be taken for every 3 months interval, HbA1c values, and daily total insulin dosage, PEDS-QL, pediatric quality of life 3.2 diabetes module scale, and pediatric quality of life 4.0 generic core scale. These are the quality of life measures in the pediatric population. Now, methodology, single group experimental study, pre and post study, ethical approval was obtained by the Institutional Ethics Committee, children with confirmed medical diagnosis of 1 year duration by the pediatrician, written informed assent and consent were obtained from all the study participants. As my study included children within the age of 16 years, so assent form was taken. 20 was my sample size by the convenient sampling technique. Now, inclusion and exclusion. In inclusion, confirmed juvenile diabetes mellitus in pediatric population, age falling 8 years to 16 years of either gender, duration of diabetes for at least 1 year, and HbA1c more than or equal to 7%. Then, patient on insulin therapy and patients willing to participate. And patients who were having uncontrolled diabetes, that is more than 250 mg per dl with urine ketones and hypoglycemia, more than frequent hypoglycemic episode, that is less than 70 mg per dl, and other systemic disorders like Cushing's, diabetic retinopathy, neuropathy, nephropathy, and morbid obesity were excluded from the study. Now, as per our FIT principle and according to our American College of Sports Medicine, the exercise where tailor-made concurrent resistance and aerobic exercise intervention was held for 8 weeks, 3 sessions in a week, duration lasting not more than 60 minutes. Each exercise was the play man. So each session of exercise was started with 10 minutes of warm-up to warm up the whole body, starting from neck rotations. This is of my own sample. Starting from neck rotations, side to side, clockwise neck rotations, anti-clockwise neck rotations. Then arm circles, arm swinging, arm crossovers, clockwise, anti-clockwise. Each warm-up exercise was done for 10 repetitions. Trunk rotations, alternate knee bends, also called as windmills, trunk extension and flexion, high knees to increase the heart rate and to warm up the body. Next, after warming up the whole body, 20 minutes of strength training was done with 1 to 2 seconds of hold and 10 to 12 repetition of 1 to 2 sets of 30 seconds rest between the sets. Started with 10 repetitions rest and 10 repetitions of 2 sets. Squats, and this is alternate backward lunges, and this is single leg deadlifts. All exercises were used by body weight training because in their home it should be convenient for them. And calf raises with 5 seconds of hold. So in strength training, I have emphasized on using up overall body, starting with lower extremity, now glute bridges for focusing on the core muscles. Now crunches. Standing bicycle crunches. 15 seconds of plank. Now we are focusing on upper body, starting with knee push-ups. Upper extremity walk downs. Wall push-ups. Now, After 20 minutes of resistance training, now each subject will perform a 20 minutes of aerobics training consisting of 10 minutes of treadmill walking and 10 minutes of cycling. If they are doing at their home setting, if they don't have a treadmill access, they can do 10 minutes of brisk and fast walking, or they can do 20 minutes of cycling alone. And ending the session with the 5 to 10 minutes of cool down. Now we have raised our heart rate, have completed our workout session. Then we will end the session with 5 to 10 minutes of cool down, where the child does deep breathing exercises, stretching of upper body, lower body and core muscles for deep relaxation and enhances good aerobic breathing. Now, even though there is a high blood glucose level, we should be very careful when the child is already on insulin therapy, because insulin already reduces the blood glucose level. We should be very careful because of the episodes of hypoglycemia. So there should be measures taken to reduce the exercise-induced hypoglycemia. Approaches that combine insulin adjustment and carbohydrate intake should be implemented. Delay of physical activity for at least 1 to 2 hours after pre-meal insulin administration. Patients should also be educated to avoid injecting insulin into the parts of the body that will be used heavily during the exercises, because there is increased blood flow to these body parts, and this result in faster insulin absorption at the start of exercise and greater risk of hypoglycemia. And also hydrating the child throughout the exercise session is very important. Then the target blood glucose to initiate the exercise session is more than 120 mg per dl and less than 250 mg per dl. Now I had taken so far these are my preliminary results, because I still not have completed my total sample size. So far I have completed 7 samples and 5 samples are ongoing. I'm regularly following them up. So now I'm presenting my follow-up study of 7 samples. Data was taken before baseline characters, before the 8 weeks and after the 8 weeks of exercise intervention. The data was normality at the baseline characteristics: age, height, weight, BMI, HbA1c level, daily total insulin dosage and PEED-SQL 3.2 scores and PEED-SQL 4.0 generic scores. Now in pre-post results, I have mentioned about pre and post, what was the difference. In HbA1c level, in pre 13.79 plus or minus 2.75, then post it had reduced to 11.47 plus or minus 1.51. In daily total insulin dosage, in pre results it was 41.14 plus or minus 13.86. In post it was 40.57 plus or minus 14.18. P-value not significant and HbA1c not significant. And in PEED-SQL 3.2 diabetes module, pre it was 44.34 plus or minus 13, and in post 55.51 plus or minus 11.46. T values were 4.42 and P value was significant. And in PEED-SQL 4.0 generic core, pre it was 51.08 plus or minus 5.72. In post it was 59.82 plus or minus 8.17. T values were 4.93 and P value was 0.02, which was significant. Since it did not show HbA1c level and daily total insulin dosage, even though I had seen the improvements in their clinical, in their values of HbA1c reports and also in their total daily total insulin, so I had to take Cohen's d to see the effect size, clinical changes. In HbA1c it was 1.03, which was large effect size, and in daily total insulin there was no much difference, 0.04, and in PEED-SQL it was large effect size 0.8, and in PEED-SQL generic model it was 1.2, which was large effect size. Now in results, The data was normally distributed at the baseline, not completed our sample size yet. These are preliminary results of 7 samples. 8 weeks of concurrent resistance and aerobic exercise significantly increased the quality of life, that is p-value less than 0.04. Then it did not reveal significant reduction in HbA1c values and daily total insulin dosage. This is my master chart just to show that because of this one E sample, he had increase in the HbA1c value from 13.2 to 13.9. The whole data is not significant. When I removed that one sample and did the statistics, the data came statistically significant. It might, in discussion I have mentioned, even though there were marked changes in the HbA1c value which was not significant statistically among the 7, we have noted HbA1c values clinically as per pre and post blood reports. Major issue we are facing is patient and parent compliance towards not following up with their pediatrician for insulin correction. As per even Shaila ma'am has told me many times, they do not come for follow-up. Even though ma'am and all the pediatricians recommend them every 3 months they have to undergo new and fresh HbA1c reports. They have to regularly monitor their fasting blood sugars, postprandial blood sugars. They do not follow it. So we were not able to correct their daily insulin dosage on the basis of their improved daily blood glucose readings. Conclusion: exercise program of concurrent resistance aerobic training can improve the quality of life and social well-being among the children suffering from type 1 diabetes. To show positive results in glycemic control and insulin dosage, there is a necessity of exercise adherence and regular following up with the pediatrician and therapist to bridge that gap. Now, this is my parent article. It is a systematic review and meta-analysis to see the effects of exercise training on glycemic control in youths with type 1 diabetes. Here, first they wanted to see glycemic control with the exercise intervention. Then they wanted to evaluate the relationship of characteristics, means what type of exercise shows how much difference in the values. Here, in the results, they not only in HbA1c level, they have showed improvements in their HbA1c level. They also reduced compared from the control group. Concurrent training interventions like more than or equal to 24 weeks, sessions more than or equal to 60 minutes shown larger changes. Like in this, you can notice this Salem 2010 and Salem 2010B. These used concurrent training, combination of both aerobics and strength training, shown improvement in the forest plot where it is not even touching the null effect line, and it has shown good results. And also in the insulin dosage, these both study have improved in the both total insulin reduction. Now, my emphasis is that the exercise, not only the prescription, the timing where when we ask the child to do the exercise, that is also important. Early morning encouraging the child is not necessary, as in the morning we know like growth hormone and cortisol will be at the peak, and exercising in the morning increases the hyperglycemic episodes. Thank you.
Thank you, Lavanya, for an enthusiastic presentation. It was indeed an eye-opener. I would like to call upon Mr. Pavan and Mr. Anil from Sun Pharma, and also Mr. Abhimanyu from Sanofi Pharma. And I ask Vinod sir and Virana Mudol sir to give a token of appreciation for them. It is my greatest honor to deliver the vote of thanks at the conclusion of this insightful CME on pediatric endocrinology. On behalf of the ongoing committee, I extend my heartfelt gratitude to our esteemed speakers for sharing their expertise and shedding light on such crucial topics. with clarity and depth. A special thanks to all the participants. Your enthusiasm, involvement made this day truly meaningful. We also acknowledge the support of our sponsors, our technical team, and the entire organizing crew for making today's event a very successful event. Thank you.